Good evening, everybody. Good evening. And so, what we will do today is we will continue from where we left yesterday and we will gradually build up on the concepts. And it is such a pleasure to be able to connect to all of you and to be able to interact with you on the chat also is so exciting. So, I usually come earlier than the class so that, I can see the chat and see what is going on in the class. It's so interesting. And so what we have done so far, I'll try to give you an overview and then I'll tell you my plan for the class today. Okay. So what we have done so far is I know radiology can become a little difficult when we have to look at multiple systems together. That is why I have divided into smaller units. I will explain to you. So far what we have done is we have done basics of CT, basics of MRI, and in between we have also looked at the diseases of the brain. This is one full unit of radiology. Then we have done chest x-ray. In the chest x-ray, although it looks like a small topic, but there are a lot of diseases, lot of cardiac diseases to look at: heart failure, rheumatic, acquired, congenital. So I have tried to cover them. Okay. And also in addition to that, what we have done is we have started with the orthopedic imaging. In orthopedic imaging, the key things that we will cover in the class are bone tumors, infections, metabolic conditions, and arthritis. So these are the usual x-rays that we have to look at in the exam. Other than that, you might revise all of this in your orthopedics also, but there are some radiological points in each of them. Like for example, in bone tumor, I explained to you how x-ray contributes to making the diagnosis. Okay, so this is what we have been doing. Let me just ask the team to look at the volume also. Okay, now so this is the plan. So what I'm going to do today is I'm going to finish with the bone tumors, the part that was left that you did not allow me to finish in the night. It was early morning only, but some students got restless, and then we look at infection, metabolic, arthritis. Then what we will do is I will start with the surgical aspect of radiology. That means how radiology helps us in surgery. In this I will look at things like ultrasound, IVP. These are the things that we will look at today. Ultrasound and Doppler, we will deal with them today, and then we will look at IVP. Subsequently, in the subsequent class, we will look at things like barium, mammography, PET scan, CT abdomen, radiation physics, radiotherapy, nuclear scan. Okay. So this is my plan. My plan is that I did not tell you my plan in the beginning so that you don't get scared. Now we have covered a lot of ground and now I can actually tell you. So what we have done is CT is done, MRI is done, neuroimaging done, bone tumor almost done. We will finish with the bone tumors. We will look at the infections, metabolic, arthritis today. Then we will look at the ultrasound and Doppler today. This will be my goal: ultrasound and Doppler and IVP today. Tomorrow we will look at barium, mammography, PET scan, CT abdomen. We'll try to finish all those parts. And in the final class, we'll look at the physics, radiotherapy, and the nuclear imaging together. Okay. Clear, everybody? Everybody follows? Okay. Now, also, I will request that today what we'll do is we'll try to take a break right at the middle of the class. So because sometimes, I see some children, they get restless here and there, but we will go with the majority today. Everybody clear? Okay. Okay. Now, once we are clear with this, let's go further, and we start building up on where we were yesterday. Okay. Everybody clear? Okay. So where we were yesterday, what we had done was we had looked at this particular X-ray. This was the X-ray. Okay. Okay. Anybody, are you clear? This was the X-ray where we were at that time of the last class that I was talking about the punched out lytic lesions in the skull, and I told you if you see punched out lytic lesions in the skull, we will use the term raindrop And also remember, multiple myeloma is one of the characteristic causes of pathological fractures of the vertebra. Other is metastasis. So if an old man comes to you with vertebral fracture with no trauma, no osteoporosis, we have to think of multiple myeloma or a metastatic lesion. So I said this is one characteristic history in the question. Okay, so this is where we were, and then I explained to you that punched out means that both inner and outer table of the skull. Punched out means that both inner and outer table of the skull are equally damaged. Okay, so the degree of damage is same, so it looks as if somebody has taken a paper punch and taken a hole out of it. Okay, this is where we were in the last class. In addition to that, I also said multiple myeloma is cold on a bone scan. Do you recall this? Do you recall this? Anybody? Did I tell you this? I said metastases are hot on a bone scan usually, but multiple myeloma is cold. Pure lytic metastases are cold. At this moment, I also said that if something is hot, it is if something is hot, we are always able to see it. If something is cold, we miss it. Okay, this is where we were in the last class. Now, immediately I am going to form conceptual level MCQ for you, and I want all of you to answer in the chat box. If you are having pure lytic metastasis in the bone, what investigation will be better? Bone scan or PET scan? Okay, just two choices बेटा. अगर वो बोलते हैं, अगर क्वेश्चन नया आ गया, ऐसा कभी पूछा नहीं, I said that usually metastases are hot on a bone scan and we are easily able to pick them up. But if they change the question and they say pure lytic bony metastases are best picked up on, then do not mark bone scan, then the answer will be PET scan. And I can see most of you are able to answer. Are you clear or not? Why not bone scan? Because pure lytic metastases are cold and we miss cold things. Hot कभी miss नहीं होती. Remember? And somebody was saying, sir, ये English में बताओ, ये बहुत मुश्किल है बता पाना. It's very difficult. Okay, it's very simple. I don't know how to phrase it in English, but if you see something hot, you never miss it. Okay, I don't know if the pun comes out or not. Okay, pure lytic metastasis, PET scan should be done. Clear, everybody? Okay, second question. Now, when I say technetium MDP, that means bone scan. Okay, but sometimes I see children get confused. I'll explain PET scan in detail, don't worry. I will talk about PET scan in detail in tomorrow's class, don't worry. So today I want you to answer this question. Okay, some bacha is saying, sir, what is hot and what is cold? Okay, hello Dr. Deepthi, how are you? I did not see in the chat that we had high command also. But remember, hot means that if a disease is picking up the isotope, it will become radioactive, we call it hot. If it is not picking up radioisotope, we call it cold. Okay, now my question to you is, there is another, everybody remember, investigation that you get confused, that is called as DEXA scan. Okay, today class till 11, now no dinner will be there, I can see. So please tell me now, DEXA scan, what is DEXA scan? Anybody? Where do we use DEXA scan in the bone? What is DEXA? Dual energy X-ray absorptiometry. Okay, dual energy X-ray absorptiometry. Anybody now? Tell me now. Everybody answer in the chat box. No more fun. Tell me, where do we use DEXA scan for? What is the indication? DEXA scan is used for, anybody? Osteoporosis assessment. Osteoporosis assessment. Okay, but they might write instead of osteoporosis. Yes, very good. I can see many of you are able to answer. Is they will say bone mineral density assessment. Okay, in short form they will write BMD assessment. Okay, everybody clear? So sometimes they might ask you directly in the exam, what is the investigation of choice? What is the investigation of choice for osteoporosis assessment? Everybody clear? Answer is DEXA. Answer is DEXA scan. But they might ask you, how will you diagnose osteoporosis on a DEXA scan? How will you diagnose osteoporosis? I will explain to you. Suppose this is the bone mineral density of a young adult. Okay, suppose this is the bone mineral density of young adult. This is -1 standard deviation, -2 standard deviations, +1, +2. Okay, and this is where we have -2.5 standard deviations. Okay, -2.5 standard deviations. Suppose your bone density, and when I say your, is usually an old person that you will come to you for bone mineral density. You know that in old age, post-menopausal osteoporosis is a problem. So suppose you have a patient who has bone mineral density less than 2.5 standard deviation as compared to young adult. Because we are comparing to young adult, we will use the term T-score. Less than -2.5 is the WHO definition of osteoporosis. And I want you to put a star mark here. And I'm sure some of you who are following us on Instagram, you might have seen. Today only Dr. Deepti had put a study mantra that whenever, if I tell you that this is a previous question, so put a Q there, so that when you are revising later on, you have your notes are categorized. If you think it is a concept, put a C. If it is a application, put A. If it is a fact, put F. If it is a question, put Q there. It is very easy then to revise in the ultimate part. Okay, so this has been multiple times as a question asked. Please, what is the WHO definition of osteoporosis? What is the answer? T-score less than -2.5. Okay, now second question is, okay, if the T-score is between -1 to -2.5, okay, this has been asked as a NEET question in the past. Anybody can answer. If your T-score is between -1 and -2.5, then anybody, can you answer? T-score is between -1 and -2.5. Bolo? Anybody? Then we will use the term osteopenia. And I want you to remember, again put a Q there. This has been asked as a question. And many people marked osteoporosis because they were not thorough with their basics. Are you clear now? So osteopenia is different from osteoporosis. Clear? Everybody? So proud of you. Now, once you are clear, with this differentiation is required because osteoporosis, we go for bisphosphonate treatment. Osteopenia, it depends on it is the patient to patient, the decision might vary. So this is the zone of, everybody, this is the zone of osteopenia. And this was osteoporosis. Okay. Now always remember, WHO is using the T-score. That means WHO is comparing with young adult. If we compare with young adult of the same sex and race, then we call it T-score. If we compare with the same age, same sex, same race, then it is Z-score. WHO uses T-score. And Sakshi, SD matlab beta standard deviation. Sakshi, which I am sure you know, आपने पढ़ा होगा बेटा कि in your PSM that mean plus minus standard deviation होता है ना, that is standard deviation. Okay. Now WHO is using T-score and this is very important. In the choice they will also say Z-score. So don't get confused. These are statistical terms, T-score, Z-score. If you compare with the same age, same sex, same race, that is T-score. If you compare with the young adult, then we use the term T-score. Everybody follows? This is DEXA scan. So again I'm repeating. I want all of you to listen to me. Bone scan matlab, bone scan is a radioisotope scan using technetium MDP for metastasis, while DEXA scan is used for osteoporosis assessment. Okay, clear? Okay, now somebody saying what is Z score? If I compare the bone mineral density with same age, same sex, same race, normal individual, that is called as Z score, Z score. Are you clear? If I compare with the same age, same sex, same race, then it is Z score. Everybody able to follow me? Okay. So once you are clear, now what I'll do is I will give you a question which will go for the next level. Let me just ask to check the audio. Okay, so let us look at one more X-ray. I'm going to zoom it. Then we will look at the X-ray. Okay, now if I ask you now to look at the skull bone here, I have zoomed it. Can you see the cortex? Can you appreciate there are tiny ill-defined holes in the ill-defined holes in the skull? Anybody? Now tell me, if you see those tiny ill-defined holes in the skull, we will use the term salt and pepper skull. Okay, this is called as salt and pepper skull. Tiny holes, just like you have salt and pepper. Or we can use a word pepper pot skull. Or we can use the word pepper pot skull. Why would you have salt and pepper or a pepper pot skull? If you have some metabolic disease which is causing calcium to be resorbed from the skull. What could it be? That is hyperparathyroidism. Okay, that is hyperparathyroidism. Salt and pepper skull, hyperparathyroidism. Any one of you can answer now. Suppose I ask you salt and pepper appearance on MRI. Can you tell me? Are you aware of any disease in which you have salt and pepper appearance on MRI? Anybody? Did I tell you that? That is glomus tumor. Glomus is a very vascular tumor. It has a lot of vessels, flow void. Then we use salt and pepper appearance on MRI. Salt and pepper appearance on skull X-ray. Hyperparathyroidism. Hyperparathyroidism. Very good, everybody. Now see. Now I want you to look at it again for the people who could not follow. This is all, the entire skull is having tiny holes, but it is best appreciated when you look at the cortex here. Can you see in the cortex, you will see those tiny little holes. Salt and pepper appearance seen in hyperparathyroidism. Now in your exam, they might ask you, where will you see, what will you see earliest X-ray finding of hyperparathyroidism? Anybody? What could be the earliest X-ray finding of hyperparathyroidism? सबसे पहले क्या होगा? Earliest X-ray finding has been asked multiple times. I will again put a Q here. Subperiosteal resorption. Okay, subperiosteal resorption. Okay, clear? Can you see those dark areas? I'm sure I think Jagdish Patel, देखो ये जो dark area है ना, bone तो white है. Jagdish, I'm repeating for you specifically. These dark areas are resorption. Okay. Now Where will you appreciate subperiosteal resorption? So I want all of you to remember, if you see this word in your question, subperiosteal resorption, go for hyperparathyroidism as the answer. Okay. This subperiosteal resorption is seen where? It is seen in the second and third phalanx, okay, on the radial aspect, in the middle phalanx. I will teach you how to see it. Okay, everybody, where do we see subperiosteal resorption first? It is seen on the second and third. So thumb is the first, second and third phalanx, middle phalanx, radial aspect. Okay. Now let's see an answer. Everybody, now we have to learn how to see it in real life. It is a difficult finding to appreciate. I want all your attention there. Okay, everybody, on the screen now, I want all of you to look at the screen now and look at this area. Okay, please look at the red arrow marked area. Can you see it, beta? Look at the red arrow marked area. Clear? Now remember that that is normal. Red arrow is the normal side. That is not the abnormality. Now see on the radial side. Look at the yellow arrow. Now see on the radial side, on the yellow arrow side, can you appreciate that there is some, I will zoom it further also. Can you appreciate this area? It looks as if somebody has scalloped the mineral away from the bone. This is subperiosteal resorption. This is how it looks like. This is how the normal cortex should have been. The red arrow and the yellow arrow is the subperiosteal resorption of bone. Subperiosteal resorption of bone is seen in, tell me, hyperparathyroidism. Hyperparathyroidism. Clear? Easy? Okay. Now, what else can happen in hyperparathyroidism? What else can happen on X-ray? Now, always remember, okay, always remember, hyperparathyroidism causes osteoclastic destruction in the bone. So because of hyperparathyroidism, you can see multiple areas of osteoclastic destruction in the bone, which can be called as anybody, any name. They can look like tumors to you. Okay, but they are not tumors. We use a term brown tumor. Okay, anybody, are you able to recall now? In pathology, they will say a term like brown tumor. It looks as if it is a tumor, but it is a misnomer. It is not a neoplastic lesion. It is osteoclastic destruction of the bone that happens in hyperparathyroidism. Now, some people are asking, sir, why it is happening on the radial side? Now, we don't know, but there is a logic here. Let me try to explain. What do we do entire day? What is the most common exercise that most of us are doing entire day? What we are doing entire day is we are taking roti. Okay, the most important exercise that most people do is take roti, bend your finger at the middle phalanx, at the radial side, break roti, eat. And when we are writing or nowadays posting on Instagram, these are the more active areas. So what I believe, probably when the hormone is more, parathormone is more, and this is where you are doing more action, so it causes this is where the changes are appreciated first. Okay, okay. So I see the damn students are sentimental about writing. That is good, because when you write, you recall later on. It is always proven. If you write, you recall it for longer time. If somebody else writes, he remembers it, you don't remember it in the exam. You need to write it down. It is very, very important. Okay, clear? Okay, now see. So sometimes what they will do is they will give you simple MCQ. Brown tumor are seen in. The answer is hyperparathyroidism. Hyperparathyroidism. Third is hyperparathyroidism also causes lamina dura resorption. Now, what is lamina dura? What is lamina dura? Let me explain. Lamina dura is the dental socket. Cortex. That means in our tooth, the socket has the cortex which is called as lamina dura. If parrot hormone is more, if parrot hormone is more, lamina dura gets resorbed. This is called as floating teeth sign. This is called as floating teeth sign. Everybody understands? Should I repeat? So sometimes they will ask you, in which condition do you see floating teeth sign? That means the tooth appears to float because the socket is destroyed because of excess of parrot hormone. That is called as hyperparathyroidism. Okay. So let me answer some questions. Sakshi, just now I said कि इसको कहते हैं brown tumor. असली में this is not a tumor. It is just a destruction that happens because of hyperparathyroidism. Are you clear? It's a misnomer in pathology. Okay, because hyperparathyroidism is a metabolic condition, causes resorption of bone, and it may look like a tumor. Hence, the pathologists call it brown tumor. Actually, it is not a tumor. Everybody? Okay, I think Farhan also had the same question. Clear? Hyperparathyroidism leads to increased osteoclastic response in the bone. Focal areas of destruction may look like tumors, so we call them brown tumors. They are not tumors. Okay, and brown is a term that has been used because of the pathology, not because of radiology. Radiology is black and white. We don't have brown. That is pathology. It has some, hemosiderin and blood products in it, so that is why it looks brown on the gross pathology. Okay, and Trisha has asked, sir, what is the difference between osteoporosis and osteopenia? Severity. Osteoporosis ज़्यादा severe है, osteopenia is less. So if my bone mineral density is between T-score of -1 and -2.5, osteopenia. If it is less than -2.5, I call it osteoporosis. Okay. And hyperparathyroidism can be primary, secondary. Yes, I will talk about it. Primary and secondary we will talk about at separate points in the class. I will talk about parathyroid imaging also, thyroid imaging also. We'll talk about that at that time. Clear, beta? Okay, and lamina dura. Lamina dura, Saranya, is the socket of the tooth. If your tooth socket, again, that is also going to have bone, and bone is getting resorbed by hyperparathyroidism. So the tooth appears to float because the lamina dura is resorbed by hyperparathyroidism. Okay, so what did I say? I said lamina dura resorption is a feature of hyperparathyroidism. Okay, now sometimes some bachas are saying, sir, can we see this image? Now it is important to restrict yourself to what can be asked. Now otherwise it will become infinite. If you notice that I have selected some things, and some things I'm only telling you in words. I'm telling you in words because this can be asked as a one-liner but not as an image-based question. Are you clear? Okay, so you don't need to do extra from what I'm teaching. You need to cover what I am teaching multiple times. That is the only thing that is required. Clear, beta? Okay. Now, how do we calculate T-score? Now, what happens is DEXA is a machine which uses two different energies of X-rays, and on the basis of absorption of those X-rays in the bone, on the basis of how much X-ray is getting attenuated, you calculate the density. Then we have the normal curve with us and you compare with the normal curve. That is how you calculate the t-score. Okay, now I think we should move forward and we have looked at most of the queries. Now let's look at one more skull X-ray. Interesting X-ray. Let's see how many of you are able to answer this. I want you to look at this area. Everybody, please look at this area. It is the skull suture. You can see the coronal suture of the skull. What is it? It is a skull suture. My question to you is this. If you can see the suture, what does this tell you? It tells you that the suture is not fused. That means we are looking at the X-ray of a child. We are looking at X-ray of a child. Now, important thing to understand is, I know many of you are able to appreciate that there are some lytic lesions in the skull. Tell me, is this multiple myeloma? Is this multiple myeloma or Paget's disease? No, because they are seen in old people. This is a child, and many times I see children, the students will do mistakes which are silly mistakes because they are not going with the basic concept. The fontanelle is open, the suture is open, it is a child. Okay, in the child you have these destructions. Okay, now how are these destructions, how do they look like? What is the appearance? Now, to me, I want all of you to listen to me. To me, it looks as if this is the African continent, this is Europe, this is Asia. It looks like a map. These are map-like destructions. Now, some bachas are saying that they are not able to appreciate the suture on the workbook, because this is correct, because whenever we print a radiological image on the paper, the quality goes down. We have to look on the screen. So please see it on the screen, you will see better. And for your benefit, the same workbook has also been uploaded in the notes section of this course so that you can see it again. This appearance is called as geographic skull. Okay, this appearance is called as geographic skull. This is not geographic lytic nahi hai febna. This is geographic skull. Okay, skull which looks like geography, map like lesions in the skull. Okay, these are typical of a condition called as Langerhans cell histiocytosis. Langerhans cell histiocytosis. These lytic lesions in the skull have a property. Yes, Shubham has picked it up correctly. These lytic lesions have a property. LCH is seen in children, and it has a property that the outer table is destroyed more than the inner table. Now, I'm trying to differentiate from multiple myeloma. Multiple myeloma was an old person with punched out lesions. Histiocytosis will be a child with geographic skull with beveled edges. Okay, are you able to understand this? Beveled edges means that the outer table, inner table will cause a sloping appearance because it has a differential destruction. While in multiple myeloma we have a typical punched out lesions, in histiocytosis you have beveled edges. Beveled edges. Are you clear? Can you remember these two MCQs? Geographic skull, beveled edges, child. Please mark the answer as Langerhans cell histiocytosis. Everybody follows? Now, once you are clear, how will they confuse you in the exam? In the exam, what they will do is, they will give you a combination and ask you what triad is it. Let's see. Suppose you have skull lytic lesions due to histiocytosis, along with the histiocytosis is causing infiltration into the orbit and your orbits are protruding. We will use a word exophthalmos. along with there is infiltration of the pituitary infundibulum. So if the pituitary infundibulum is infiltrated, it leads to diabetes insipidus. Suppose you have these three combination in histiocytosis. What do you call it? What is the combination? Anybody? Lytic lesions in the skull, exophthalmos, diabetes insipidus. Anybody? Anybody answer this? This is called as Hand-Schuller-Christian triad or Hand-Schuller-Christian disease. So in histiocytosis, a patient may present with a characteristic triad of skull lytic lesions, exophthalmos, diabetes insipidus. Okay. So LCH matlab Langerhans cell histiocytosis. This is what you see in children. Okay. Everybody understands? Histiocytosis can not only affect the skull, it can also affect the vertebra of the child. Now I want all of you to focus on this image so that I can tell you the anatomy. Suppose this is your disc, vertebra, vertebra, vertebra. Now I want you to see the vertebra which is marked by the arrow. You can see the disc on either side. Can anybody help me and tell me what has happened to this vertebra? I want all of you to look at it and tell me what has happened to this vertebra. Anybody? What has happened to it? The vertebra has collapsed. Because of histiocytosis, the vertebra totally collapses. Single vertebra collapses and becomes totally flat and plain. So, if it is totally flat and plain, we use a term vertebra plana. So, what is the classic cause of vertebra plana in a child? It is again a previous question as well. It can be asked again also. It's a potential question. The answer is Langerhans cell histiocytosis. Vertebra plana in a child, always remember LCH as the cause. Now one bacha is saying, can we have it in TB? Can you have it in TB? Can tuberculosis of the spine lead to vertebra plana? The answer is yes, but usually TB is paradiscal. Usually TB will involve the end plates. But tuberculosis can be central. It can involve the center of the vertebra if the tubercular bacilli spreads through the Bateson plexus, spreads through the veins and involves the vertebral body. Vertebra can collapse and it can lead to vertebra plana. So TB can also lead to vertebra plana, but if it is central variety where the spread is venous, not arterial. Okay, and I think Chirag Gowda and everybody was able to guess the answer already. Now, ek bacha was saying, what is inner table and outer table? So, if you go back to your anatomy days, skull ko, if you touch your skull from outside, this is the outer table. If you touch it from inside, it is the inner table. There are two parts. In between, you have diploe. In between, you have the diploe. Now, so Goku Tiwari is again and again saying, sir, ye to bacha hai. How can he be so? So, please see. That is where you need to understand in the class. LCH can also be pulmonary. Langerhans cell histiocytosis can be pulmonary. It can affect the lungs. But pulmonary LCH is only seen in smokers. आप समझे गोकू तिवारी? Are you clear बेटा गोकू? Are you clear or not? कि bone में LCH है. Bony LCH is seen in children. It has nothing to do with smoking. But in lungs, Langerhans cell histiocytosis is seen in smokers. Are you clear beta? Are you able to understand? Are you able to follow my point? Okay. Now let me again repeat for all of you. I will repeat it for you, but don't worry. My question to you is, Langerhans cell histiocytosis in lungs is typically seen in smokers. Okay. Everybody listen to me and answer. Now if you smoke, you should not smoke actually, but if you smoke, the cigarette smoke goes up. Remember, and let me just explain to you that, you know, the whenever somebody smokes, the ash goes down, the smoke goes up. राख नीचे जाती, धुआं ऊपर जाता है. So we all know that smoke goes up, 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 upper low predominant. This is how you remember forever. Langerhans cell histiocytosis of the lung is upper low predominant, seen in smokers, lead to cystic changes and nodules. Okay, everybody understands? Now TB, I'll talk about tuberculosis of the spine again, so we can skip that part. That usually what happens is, I'll just explain to you, some of the bachas have not heard of it. Now TB artery, tubercular bacilli, the mycobacterium goes through an artery which will supply the disc and both the end plates. This is how TB is usually paradiscal. But vertebra also has a venous plexus called as Bateson plexus. So if the tubercular bacilli spreads via the vein, it involves the center of the vertebra, leads to vertebra plana. Okay, everybody understands this? Everybody follows? Okay, we'll talk about this again also when I show you the image of TB, and we'll talk about TB. But are you able to answer that this is a separate variety altogether, where this is seen in smokers? Pulmonary Langerhans cell histiocytosis is seen in smokers. Everybody, are you able to follow my point? Yes? Okay. Now, my question to you is this. Let's see how many of you are able to answer this. Langerhans cell histiocytosis is also called as eosinophilic granuloma. So sometimes what happens is, I'll give you an example. Sometimes they give you an X-ray like this in the exam of a child, and in the choice they give eosinophilic granuloma. Don't panic, it is same as LCH. Okay, are you clear? So I said TB can spread through the arterial route, which is usual part where you have a paradiscal variety of tuberculosis of spine, but can be venous. If it is venous, it involves the center of the vertebra. So this is the logic behind why tuberculosis can, in some patients, most patients it will involve the end plates, but some patients it can involve the center of the vertebra. That is the logic. Clear? Everybody understands? So LCH in the lungs is seen in young adults, not in children, beta. That is what I'm trying to say. Bony LCH has nothing to do with smokers. हड्डी में LCH जो हो रहा है उसका स्मोकिंग से कोई लेना देना नहीं है, वो बच्चों में है. But LCH in young adults in lungs is being seen in smokers. Okay, Upu? Everybody follows? Okay. So this was a short summary on image-based questions, radiological questions on Langerhans cell histiocytosis. Okay. Everybody clear? Now let's go further. Now what my question is, can we have infection in the bone? Yes? Yes, possible. So infection of the bone will be called as osteomyelitis, which can be acute, chronic. Let us write acute osteomyelitis first. And let us write the first MCQ here. What is the earliest X-ray finding in acute osteomyelitis? Anybody? Okay. Anybody, please answer. What is the earliest X-ray finding of acute osteomyelitis? Okay, so I think before we see, let me take some questions. Divya Gupta is saying, sir, bone scan is used for metastasis? Yes, mostly for metastasis. Okay. Now, earliest X-ray finding of acute osteomyelitis is soft tissue swelling, which can be written as blurring of tissue planes. Are you clear? So earliest X-ray finding of acute infection in the bone is soft tissue swelling, which can be written as blurring of the tissue planes. That means initially you cannot appreciate on the X-ray. Okay, bony destruction due to osteomyelitis is appreciated only after 7 to 10 days. Okay, so they might ask you in the exam, after how many days bone lesions are appreciated in acute osteomyelitis on X-ray. So bone destruction on X-ray is appreciated after 7 to 10 days. Bone destruction is identified on X-ray after 7 to 10 days. Now my question is this, and this is a very important question I want all of you to answer. What is the investigation of choice for acute osteomyelitis? Anybody? What is the investigation of choice for acute osteomyelitis? Investigation of choice for acute osteomyelitis is not X-ray. It is not X-ray. What is it? Because X-ray cannot tell for 7 to 10 days for sure. It is MRI. What MRI sequence? Stir. If we suppress the fat by MRI, we use a technique called as stir. Remember, I talked about it when I was talking the MRI, which can show me bone marrow edema as early as 24 hours of onset. I can see most of you are able to pick it up, but remember, investigation of choice for acute osteomyelitis is MRI. MRI can pick up bone marrow edema as early as, again this is a question, as early as 24 hours of onset. 24 hours of onset. Very good. Now my question to all of you is, now what will happen? If you have infection, what will happen if it goes on for a long time? If it goes on for a long time, suppose this is your bone. Okay. Now, and suppose this is the infection in the bone, in the metaphysis, you have some infection. If the infection goes on for a long time, what will happen? It will have some, dead WBCs, dead bacteria. What is this? Pus formation. And the pus formation will cause lifting up of periosteum. So if I call pus as abscess, I will use a term. It will form subperiosteal abscess. Okay, subperiosteal abscess. Okay, Ankit, I hope you are now able to follow. कि bone में बीमारी है, there is osteomyelitis, but still on the X-ray bone damage will be seen only after 7 to 10 days, because you need a certain amount of bone destruction to become evident on X-ray. Okay, so that is why MRI is better, because it can pick up bone marrow edema almost on the same day of symptoms of onset. Okay, so in acute osteomyelitis, it will continue. If the infection continues further, it will lead to a subperiosteal abscess. If there is subperiosteal abscess, then what will happen? Periosteum has a function. Everybody listen to me. Periosteum has a function to give blood supply to the underlying bone. So if the periosteum and bone are separated by pus, this lower part, the part of the bone, will not get blood supply because the periosteum is elevated. This tissue will start to die. This dead bone that happens in the infective process is called as sequestrum. This dead bone is called as sequestrum. Anybody? What is sequestrum? Sequestrum is the dead bone seen in pathognomic of chronic osteomyelitis. Pathognomic feature is sequestrum. Are you clear? So always remember, they will say, what is the pathognomic, like most important X-ray feature of chronic osteomyelitis? So what is the answer? The answer is sequestrum. Now what is sequestrum? Sequestrum is the dead bone. Now how will you identify it? Now if a bone, I want all of you to listen to me, it is very important. if a bone is viable, it will have blood supply. Now because of blood supply, what the blood supply does, it takes calcium away from the bone. Okay, so what is happening in our bone is bone and blood calcium are in physiological balance. So blood is constantly taking the calcium away from the bone, bone is building calcium. Now tell me, if you have dead bone, what will not happen? If you have dead bone, what will not happen? Tell me. If you have dead bone, this blood supply and the demineralization will not happen. So that means if you have dead bone, the calcium from that bone will not be resorbed. Okay, so what happens is, paradoxically, dead bone on X-ray appears more dense. Okay, always remember, dead bone X-ray पे ज़्यादा white दिखेगी as compared to the surrounding bone from where the demineralization is happening. Dead bone will appear more dense. Can you mark it in the exam? Just forget about the reason, but at least keep it in mind. Sequestrum is the dead bone. On X-ray, it will appear more dense. It is pathognomic for chronic osteomyelitis. Okay, I am again repeating for Shivam and Janvi and Abhishek. देखो, chronic osteomyelitis में acute से क्या फर्क होगा? If infection continues for a long time, you will have abscess formation which will compromise the blood supply of this part. It will become dead, dense, called as sequestrum. Okay, now tell me. Now what else will happen? The body will try to heal and try to control the spread of the infection. What will happen? Periosteum will start to make new bone below it. Periosteum will start to make solid new bone below it. This new bone that is formed is called as involucrum. Okay, are you clear? So sequestrum is the dead dense bone, involucrum is the new bone which is getting formed, because we want to build a wall to stop the spread of infection. Infection is in the bone, body wants to stop the spread to the other organs. But places where, listen to me everybody, places where the periosteum is necrotic, there will be places where there is periosteal damage. At those places, new bone cannot form. So what happens is, in chronic osteomyelitis, you have some new bone formation, some hole, some new bone formation. This hole in the involucrum is called as cloaca. This hole in the new bone is called as cloaca. Okay, so periosteum has two functions. It forms the bone, it gives blood supply to the underlying bone. So if the periosteum is elevated for a long time, it will form bone below it. Okay, now this hole in the involucrum is called as cloaca. Now second function is, pus is dead WBCs, dead bacteria, sequestrum is dead bone. Our body wants to throw the dead tissue out. Now what will happen is, our body will throw the dead tissue out with force that will create a sinus tract, and the patient will come to you. The clinical history will be chronic discharging sinus. The clinical history will be chronic discharging sinus. My question to you is this. In the exam, they will make a MCQ like this. Patient comes to you with a chronic discharging sinus. What X-ray finding is pathognomic of chronic osteomyelitis? What is it that is pathognomic? Please mark the answer as sequestrum. Pathognomic finding is sequestrum. Everybody understands? Clear? Okay, beta. Now let me ask you another question. Before I go onwards, let us try to identify it first and then we'll talk about it. Let us try to see one X-ray together, and I am already able to see that most of you are able to answer this. But let's see how many of you are able to tell me. Look at this part which I am putting arrows at. Look at this part. Can you see this dense white bone? More dense than anything else? That is sequestrum. And can you see there is new bone formation over it? Involucrum. Okay. So what is your diagnosis? If you see sequestrum, dead bone, new bone formation like this, what do you think your diagnosis is? Our diagnosis is chronic pyogenic osteomyelitis. What is your diagnosis? Chronic pyogenic osteomyelitis. Clear? Everybody understands? Now, my question to you is this. In the exam, they will say, if this is chronic pyogenic osteomyelitis, why this is not tubercular? Why pyogenic? Why not tubercular? Okay, and this is one of the questions that you keep getting in your exams. In India, they will ask you TB. What is the X-ray feature which differentiates pyogenic from tubercular osteomyelitis? Anybody? Anybody? Anybody can answer this? Tubercular osteomyelitis, the bone will show osteoporosis plus with almost no new bone, almost no periosteal reaction. So tubercular osteomyelitis, on the other hand, is difficult to identify because all you see is involved bone will have osteoporosis with almost no new bone, no periosteal reaction. Okay. Now I want all of you to see with me again. एक बार मेरे साथ दोबारा देखो. Can you see the amount thick new bone being formed here? Yes. So this must be pyogenic. In tuberculosis, you will never have so much new bone formation. Tubercular osteomyelitis, only thing that happens in the bone is the bone shows significant osteoporosis. The bone shows significant osteoporosis. Okay. Now, another thing I thought it is interesting for you to see today, if I zoom it for you fully, I want you to put your eyes on my X-ray. Just look at my X-ray and look at this area, beta. What is this? New bone. What is this? New bone. Okay. Now please see this area. Do you see that this area is a hole in the involucrum? This involucrum is so thick. Here it has become, suddenly it is gone. What is this? This is the cloaca which I talked about. Cloaca is the hole in the involucrum through which the pus and the dead bone are getting discharged into the discharging sinus. Clear? Okay. So what we have done is I have shown you that acute osteomyelitis, go for MRI. Chronic, you can see it on X-ray if you see the sequestrum. Okay. And we have also seen difference between pyogenic and tubercular osteomyelitis. Now the question is this. This is slightly more difficult and I want you to appreciate with me without typing. I want you to try to appreciate and try to understand, because if you understand once it is good. If this is femur, this is your tibia. Okay. Now I will zoom it and I want you to understand that there is a disease in the tibia. In tibia, you can appreciate there is a lytic lesion surrounded by sclerosis. So this is the lytic lesion. This is the area where I want you to look at. Okay, I'm again increasing the size. There is a ill-defined lytic lesion and surrounding bone is having sclerosis. Bone is appearing more white. Okay. So what is it? A lytic lesion plus surrounding sclerosis. A very delicate finding. Okay. Now let's imagine what is going to happen. Okay. Let's imagine what's going to happen. Now the question is, let's try to understand why would you have lytic lesion? Lytic lesion means there is destruction happening. And why would you have sclerosis? That means there is healing happening. ये कैसे हो सकता है? There is damage, destruction and healing. Normally in our body, acute processes will cause destruction. Chronic process, you will also have some healing going on the side by side. Here you have acute process also going on, chronic process also going on. Destruction is also there, healing is also there. Both are happening together. What does this mean? This means we are looking at a case of subacute osteomyelitis described by Dr. Brody. So we call it Brody's abscess. Most common site, upper end of tibia. Are you able to understand why it is subacute? This is subacute because we have both lytic lesion and sclerosis happening together. This is a subacute process called as Brody's abscess. Clear? Now one bacha is saying, sir, I think one bacha was asking this question in the past. I think it is very difficult to diagnose tubercular osteomyelitis only on X-ray finding. I will explain it when I talk about tubercular arthritis. Have patience. Every one of your questions will be answered in the flow. I have some plans for you where I will fit everything in. Okay. Now, my question to you is this. This is something which we will write as a fact, and just remember it. They will never ask you to go into the MRI of this, but there is one sign which is nowadays being asked to PGs, so it might come to you, which is called as penumbra sign on MRI. Okay, it will not come as a visual, only a fact. Remember, penumbra sign on MRI is seen in subacute osteomyelitis like Brody's abscess. Penumbra sign on MRI is seen in Brody's abscess. Okay, and I think Tamil Selvan has asked a question, sir, how to differentiate from osteoid osteoma. Osteoid osteoma will be a well-defined nidus in the cortex, while the Brody's abscess, the destruction will not be that well defined. There will be some tunnels going into the bone because this is an infection, while osteoid osteoma was more well defined, a benign tumor. So this would have tunneling into the, it will not be just a lytic lesion, it will, you will see some tunnels going into the surrounding area. Okay. Okay. So let's revise what we have seen: osteomyelitis acute, chronic, subacute. Now my question to you is this. Let us look at, and I saw some people were wanting to ask about this also. I want you to look at this spine MRI. This is a spine MRI. Which plane? Sagittal plane. Okay, this is a MRI of the spine. My question to you is this. Anybody now look at it and answer. Look at the vertebra. Look at the vertebra and tell me, why are the vertebra appearing dark? Anybody? Why are the vertebra appearing dark? They should have bone marrow fat. On MRI they should appear white because of the bone marrow fat. The vertebra are appearing dark because we have suppressed the signal from the fat using stir. Okay. Everybody, we have suppressed the signal of the fat using stir. My question to you is this. Directly answer. If the fat has been suppressed, why is this vertebra, intervening disc, surrounding soft tissue, why is this area appearing bright? If the fat is suppressed, then why is this vertebral body and the disc appearing bright? Because they are inflamed, they have edema. If they have edema, I will write it as spondylo. Spondylo means vertebra. Disc means disc. Itis means inflammation. I will say spondylodiscitis. There is inflammation of the vertebra and intervening disc. Now, how our, embryologically the vertebra are made, you will read about this at detail in your anatomy class. What happens is, if this is your disc, intervertebral disc, okay. Now, the embryologically, the unit that is forming one embryological unit here is, let me just explain. Embryologically, when we look at the vertebra, this is the disc. Half of one vertebra, disc, and this is one embryological unit. And the artery of this unit will be common. The blood vessel of this unit will be common. Okay. Now the artery which is supplying the two end plates will be same. So any infection which is coming through the hematogenous route, through the artery, is going to be paradiscal. So tuberculosis is most commonly paradiscal. This is what I was trying to tell you in the class. Are you clear, beta? Are you able to understand this? Okay. Are you able to understand this? Now, is that question clear? That some people are asking, why is TB paradiscal? But this is not the only blood supply to the vertebra. Vertebra also has the vein, which is due to the venous plexus, which is called as the Bateson's venous plexus. So if the tubercular bacilli goes into the venous plexus, then what happens is it involves the center of the vertebra. And that is what I was explaining at that time. If the center of the vertebra is involved, then the vertebra will collapse and become plain. Otherwise, it will usually involve the vertebra and the disc. Are you clear, beta? Are you able to answer this? Okay. Now, my question are these. What is the investigation of choice for port spine? What is the investigation of choice for port spine? Anybody can answer? Anybody can answer? It should be MRI, because MRI can show me edema, MRI can show me the spinal cord, it can show me the compression of the cord if that happens. So MRI is the investigation of choice. Clear? Okay. So what we were trying to say is that if you ever see that the vertebra and disc, now if you ever see involvement in this area, this is what I want to say, end plate and the disc. That means it is a infective process, which is typically tuberculosis in our country, because TB is usually paradiscal. An important thing to understand is that disc is a avascular structure. Disc is a avascular structure. So if the infection involves the end plates, the nutrition of the disc is affected and disc collapses. So if they ever ask you, what is the earliest X-ray feature of port spine? What will you mark? Investigation of choice आपने बताया MRI है, but if they say what is the earliest X-ray feature of port spine, then the answer is loss of disc space. So now I hope you are able to identify that the MRI that I have shown to you is port spine, because it has two vertebrae are involved and the disc is involved. If the two vertebra disc are involved, we always think of infective process, which is typically tuberculosis in our country. Clear? So this is a MRI image showing us port spine, which is same as TB of the spine. Okay. So I'm again repeating, earliest X-ray feature of port spine is loss of disc space. Earliest X-ray feature of port spine, loss of disc space. Okay, clear? Now let me ask you a question now. Suppose they change a question, they change the question to this. Suppose in the exam they ask you a question like this. Let's see if you can answer. A patient who was consuming non-pasteurized milk products, okay, develop fever and develops fever, backache. X-ray was done, revealed erosion of the anterosuperior corner of the vertebra. So that means we are dealing with the infection, which is common in people who consume non-pasteurized milk products. Fever tells you inflammation, backache tells you that the infection is in the vertebra. X-ray is confirming that there is involvement of the superior corner of the vertebra. This is typical finding of an infection called as, anybody? Brucellosis. So don't forget, brucellosis can also lead to vertebral osteomyelitis, but it has predication to anterosuperior corner of the vertebra. This was described by a man called as Pedro Pon. So we use a word Pedro Pon sign on X-ray. What is Pedro Pon sign? Erosion of the anterosuperior corner of the vertebra seen in brucellosis. So although commonly in vertebra, if you see infection, we think of tuberculosis, but brucellosis is also one of the cause where the MCQ will have these three keywords written in the question. Okay, everybody follows? Okay. Now, so far we've seen some infections. So we saw tumors, infections. Now let's look at metabolic process. Metabolic process that I want to show to you today is going to be rickets, because I don't want to go to hi-fi. I want to stick to what is asked in the exam, rickets. Now my question to you is this, rickets beta, anybody tell me rickets, है ना? Due to deficiency of vitamin D. Now why do we need vitamin D? Let me explain to you. In bone there are two processes. First you have the matrix that is formed, which is osteoid, then it gets mineralized. And where do you need vitamin D for? Where do you need vitamin D for? Anybody? Where do you need vitamin D for? Vitamin D is needed for the mineralization of bone. It is needed for mineralization. It is not needed for osteoid production. So if vitamin D deficiency is there, mineralization will not happen. Clear? Okay. So in rickets, sometimes they directly ask you this question. So people are reading hi-fi things. Sometimes they directly ask you what is happening in rickets. There is defective mineralization of the bone. Okay. Everybody follows? Okay. Okay. Now my question to you is this. Let's see how many of you can answer. In the exam, they will say, what is the earliest X-ray feature of rickets? What is the earliest X-ray finding of rickets? Anybody? Now let's try to understand. Let's try to understand. Okay. Suppose this is your bone. Everybody see with me. No need to write. We will write only one line. If this is your metaphysis, growth plate, epiphysis. In rickets, what happens is this line, okay, try to imagine this was your growth plate. So this line, which is this is cartilage, growth plate is cartilaginous. This is where the bone is formed. In between the zone, that the zone is lost. This line becomes blurred. This is called as loss of provisional zone of calcification. Can you mark it in the exam? Okay. What is the first X-ray finding? Okay, some of you are saying widening of growth plate. That is not the first. First X-ray finding will be loss of provisional zone of calcification. That means right next to the growth plate, the bony part of the metaphysis will become blurred. Loss of provisional zone of calcification. Now after this, what will happen? After this, we need to understand, it is very important that you give me all your attention right now. Very, very important question. After this, what will happen is, suppose this is your bone, metaphysis and epiphysis. Now if your vitamin D is not there, mineralization cannot happen. So what will happen? You will lose the provisional zone. Then osteoid will be accumulating. Suppose this is your growth plate. This is osteoid. Osteoid will be accumulating, but it will not be getting mineralized. So what will happen? There will be accumulation of unmineralized osteoid at the growth plate. I'm repeating beta. I want all of you to be very clear on this. एक बार बताओ, rickets में because of vitamin D deficiency, there will be accumulation of unmineralized osteoid at the growth plate. As a result, when you see on the X-ray, this area will look, anybody? When you see it on the X-ray, what will be the appearance of this area? This area will appear widened. and the X-ray will show growth plate widening. Are you clear? So very classic question, very often asked, and I think Janvi Rai and GM Rahul were already able to answer this. Growth plate widening on X-ray is a feature of, what will you mark as the answer? Rickets. Why does it happen? It happens because of accumulation of unmineralized osteoid. Why it is not getting mineralized? Because of vitamin D deficiency. Okay. Second question. Now in rickets, the bone is soft. The name itself is telling us the bone is soft. So what will happen is, all of you please see with me, this, okay, listen to me beta, listen to me, this unmineralized osteoid will push into the metaphysis. When it push into the metaphysis will become like this. You understand? Dekho, suppose this is the bone and you push against it, it will become broader. Okay, this is called as splaying of metaphysis. समझ पा रहे हैं? Metaphysis का फैल जाना is called as splaying. Clear? And second thing that will happen is, if you keep pushing into the metaphysis will become round. This rounding of metaphysis is what you see here. This is called as cupping of metaphysis. Are you clear? So are you clear now? Widening growth plate की आकांक्षा आ रही है. Widening is of the growth plate. This area is the growth plate. ये widening है बेटा. Okay. But cupping is the cupping of the metaphysis. I will show it to you by zooming the image. Please see this here. Can you see the metaphysis, how it looks like a cup? And second, it is broader. We call it splaying. Third thing is, so cupping, splaying are happening in the metaphysis of the bone. The changes of rickets are happening in the metaphysis. Are you clear, beta? Okay. Now, second thing is, look at the border of the metaphysis. It is not going to be smooth because it is some defective mineralization happening here. So it is going to be irregular, like a brush border. This is called as fraying. So clear? Let us repeat. In rickets, this unmineralized osteoid will push into the metaphysis and it will cause remodeling of the metaphysis. The metaphysis will become splayed, cupped, frayed. Splayed मतलब is फैल गया है. Cupping मतलब गोल हो गया है. Fraying मतलब irregular है. I'm again repeating, there are three things. There are three changes of metaphysis which are happening in rickets: splaying, cupping, fraying. Simple? Okay. Now, next question is, if you give vitamin D to this patient, what will happen? If you give vitamin D and the patient is responding or patient is healing, what will happen? If you give vitamin D to the patient, what will happen? Now, there is a rule in life that the student who goes out of the class first will come back first. That means, what was lost first in rickets? Provisional zone of calcification. So if you give vitamin D, what will recover? Provisional zone of calcification will recover. So in healing rickets, you will see recovery of provisional zone of calcification. Okay. So some बच्चा is saying, what was fraying? Fraying मतलब था irregularity. Please see it again, बेटा. अभी दिखाता हूँ. I want all of you, bachas, to focus on what I am saying. There is very little to write actually in the class, if you notice. It is more to understand the images. See the irregularity. The border of the metaphysis will be having irregularity, which is called as fraying. Fraying मतलब irregular है. Fraying. Yeah. Okay. Now, again I am repeating. So this is a X-ray of rickets where you see growth plate widening, cupping of metaphysis, splaying of metaphysis, fraying of metaphysis. So what will happen? In healing, you will see healing rickets, you will see recovery of the provisional zone of calcification. So if we see healing rickets, you will see that right next to the growth plate where we have the provisional zone, calcification will come back. So if you see healing rickets, the X-ray will look something like this. You will see a white line at the area of provisional zone of calcification, and it will start showing mineralization first. Then the entire bone will heal. First you will see recovery of the provisional zone of calcification, which is called as white line of Frankel, which is called as white line of Frankel. Are you able to understand my question? So I am again repeating. So sometimes in the exam they will confuse you by saying white line of Frankel is seen in rickets. True or false? Answer is false. It is not seen in rickets, it is seen in healing rickets. Many people get it wrong in the exam. White line of Frankel is seen in healing rickets. It represents recovery of provisional zone of calcification. Okay. Loss of provisional zone of calcification was the first step when rickets happened. So in healing rickets, it is recovered first. Are you clear? Okay, this is called as white line of Frankel, and I see that some of you are able to answer. Now I am going to add a difficulty level to you. Let's see if you can answer better. Okay, let's see if you can answer. Okay, suppose you have vitamin D deficiency in adult. Suppose you have vitamin D deficiency in adult, then what will happen? Anybody? If you have vitamin D deficiency in adult, we call it osteomalacia. We call it osteomalacia. Okay. Now what is osteomalacia and how will it look like? To see the changes of osteomalacia, we need to look at the X-rays of the pelvis and X-ray of the chest. We need to look at pubic rami, neck of femur, outer border of scapula, ribs. I am again repeating. So sometimes they will ask you, which two X-rays will you advise for suspected osteomalacia? Pelvis and chest. What are you going to look at? Look for pubic ramus, neck of femur, outer border of scapula, ribs. Okay, are you clear? So I hope Netha, are you clear now? Not knee, not the knee. We will look at these four locations. These are the characteristic locations to look for changes of osteomalacia. Osteomalacia is different from osteoarthritis. Don't get confused, beta. Okay, osteo matlab haddi, malacia matlab softening. Okay, now tell me, what are we going to look for? Now what happens is, I will explain to you. Suppose these are your pubic symphysis, pubic rami. Okay. Okay, so suppose this is the extra image, beta, don't worry, extra image I'm showing in the class. So suppose these are your pubic ramus, pubic rami. Symmetrically on both sides, there will be areas in the bone where you will have unmineralized osteoid, islands of unmineralized osteoid. Okay, anybody tell me? Anybody now tell me, why do you have this unmineralized osteoid here? Because vitamin D is deficient. Now this is the difference between adult and children. In children, the growth plate is open. So in rickets you saw growth plate widening. But in adults, growth plate is already fused. So what is happening is, in the areas where you have weight bearing, you need vitamin D for the turnover, and if the vitamin D is deficient, you will see islands of unmineralized, tell me, unmineralized osteoid. Clear? Now tell me, beta, let's see if you can answer. Now, because this area is not mineralized, on the X-ray they will not be, on the X-ray they will be seen as a break in the cortex because they are not mineralized. So these are called as pseudo fractures, also called as Loser's zone after Dr. Loser, who described it, also called as milkman's fractures after Dr. Milkman. Okay, all three mean the same thing. Should I repeat? So what is the pathognomic feature of osteomalacia? Answer is loser zone, also called as pseudo fractures, also called as milkman's fractures. Okay, how will they look like? Now what will happen is, this is an X-ray of a patient with osteomalacia. This is the X-ray of the pelvis, like I already explained to you. Look at this area. Look at this area here, here. Can you appreciate there are, okay, I'll zoom it also. There are these breaks in symmetrically present in the pubic rami. These are what are called as loser zone. Another thing that is interesting to see here, okay, it is in the pelvis it is usually symmetric, not in the other bone, but pelvis it is usually symmetric, beta, area. But beta, my question to you is this. Now osteomalacia में ना bone soft हो गया है, osteomalacia में bone softening है. So if I put my weight on the hip joint, what will happen? Because of softening of the bone, the weight will cause pushing of the hip into the pelvis. Hip joint pelvis के अंदर ऐसे protrude करेगा. Okay. As a result, when we see the pelvic cavity, it looks, what is the shape of pelvic cavity? It looks triangular. It looks triangular. This is called as triradiate pelvis. Okay. The image is not so important, so it is not there in the image book, but just to understand, I added it as a add-on image in the discussion because I thought, you know, some children need to see it to understand. I'm again repeating, in your exam they will directly ask you a question, which condition shows triradiate pelvis? What is your answer? Osteomalacia. Osteomalacia. What is the pathognomic finding of osteomalacia? Pathognomic finding of osteomalacia is loser zone, which are also called as pseudo fracture, typically seen in pubic ramus, neck of femur, outer border of scapula, ribs. Okay, pathognomic feature is loser zone. Loser zone. Rashika Shekhar. Are you clear? Now, so the unmineralized portion on X-ray will be dark because the bone is white. If there is no mineral, it will be dark. It will look like a fracture. Okay. Now, this is the fracture. If you notice the dark line here, in a dark line here. Now why it is looking slightly white is because of, you know, because of the fracture you can see some overlapping segments. The fracture is the darker one. Okay. Okay beta. Okay Fennel. Okay. Now let me ask you a question now. You've understood this, the triradiate pelvis. What will happen to the vertebra? In osteomalacia, what will happen to the vertebra? Okay. Now in osteomalacia, the bones were becoming soft. Because of the weight of the hip joints were protruding into the pelvis and the pelvic cavity was becoming triangular. We use the term triradiate pelvis. Clear? Arpita and Shreya. Okay. Okay. Now what will happen to the vertebra? What will happen to the vertebra? Now vertebra also becomes soft. In osteomalacia, if you put weight on the vertebra and they are soft, what will happen? Same thing will happen that is happening to your chair right now, because you are sitting on the chair for a long time, the chair gets depressed, especially if the foam is soft. So vertebra, if they are soft, in osteomalacia, they start becoming biconcave like this. This is called as biconcave vertebral bodies, or we use the term codfish vertebra. So in which condition do we see codfish vertebra or biconcave vertebra? It is seen in osteomalacia. Same appearance can happen in osteoporosis because of bone weakening, but the single best answer is osteomalacia because it is a feature of bone softening. So codfish vertebra seen in osteomalacia more than osteoporosis. That means both of them are correct statement, but if you have to pick one, please mark osteomalacia in the answer. Everybody follows? Okay. So this is what we have been covering so far. We saw rickets, osteomalacia, and different signs of common diseases like this. Now, if I go further and ask you, another vitamin deficiency which can affect the bone is vitamin C. Vitamin C deficiency is called as scurvy. Vitamin C deficiency is called as scurvy. Okay, clear? So we have to now differentiate rickets and scurvy, and also because I see some bacha is also asking this question here, that the triradiate pelvis that we saw here is, and somebody was asking about sickle cell anemia also, Webhub I think. So let me explain, go into a little bit more length. In sickle cell anemia, what will happen to the vertebra in sickle cell anemia? Anybody? Now sickle cell anemia, sickling of the RBC causes obstruction to the vessels. So it causes vascular occlusion. So the end plate vessels, the blood vessels supplying the end plates get occluded. So end plate will develop infarction. End plate will get infarcted. Now what will happen? The end plate will collapse because of the weight and the weakening because of infarction. The end plate will collapse. Okay, I'm again repeating bit. It's slightly difficult, but it is interesting to note. Sickle cell anemia mein the vertebrae are not soft. They are not soft. It is the end plate which have become infarcted, so it will fall down like this because of infarction. This is called as H-shaped vertebra. H-shaped vertebra. Okay, are you able to understand? Are you clear now, beta? I think the bacha that was asking this. H-shaped vertebra, Priyal I think was asking, Webhoff, H-shaped vertebra seen in sickle cell anemia. Okay, now also when we say triangular pelvis, we also need to consider important condition, important autosomal dominant cause of dwarfism, which has some one-liners to remember. Can you name a very, very important autosomal dominant cause of dwarfism? Anybody? Can you name it? The answer is achondroplasia. It is a autosomal dominant problem which affects the enchondral ossification of the bone, achondroplasia. Now, in achondroplasia also, the vertebra have a typical shape and the pelvis has a typical shape. The pelvic cavity in achondroplasia also is broad at the inlet, narrow at the outlet. Okay. In achondroplasia also, the pelvis has a broad inlet, narrow outlet, and it has been called as champagne glass pelvis. Okay. Clear? Everybody follows? Should I repeat? Should I repeat? Champagne glass pelvis is seen in achondroplasia and triradiate pelvis seen in osteomalacia. These are the best language that we use in the MCQs. Second thing to remember is achondroplasia, it's a cause of dwarfism, so it will have some other findings also. Can you tell? It will lead to rhizomelia. That means the proximal bones are shorter. Proximal bones means femur and humerus are more short. It is rhizomelic dwarfism. It will affect the proximal bones. Any other finding you know it? Hand in achondroplasia will become like this. Okay, let me show it to you. Hand in achondroplasia will become like this. Okay, everybody see with me? There will be a gap between the middle finger and the ring finger. Okay, so you will have three pointers: thumb, these two fingers, these two fingers. This is called as trident hand. Okay, in which condition do we see trident hand? Achondroplasia, achondroplasia. And when we will meet after many years, after many years, suppose you and me meet on a airport or on a railway station or a bus stop, and suppose you recognize me, and we do not know if I am Dr. Sumer or not, I will become old, you will become, more young, and we don't know. Then we will meet and say, secret symbol. Okay, so in which condition do we see trident hand? Achondroplasia. Champagne glass pelvis, achondroplasia. And also remember two more named signs: tombstone shaped iliac blades, chevron like epiphysis. Chevron means like a triangle, chevron shaped, a triangular shaped epiphysis, tombstone iliac blade. एक बच्चा कह रहा है सर व्हाट इज rhizomelia? Rhizomelia means, okay, rhizomelia means, everybody remembers, proximal bones are shorter. It is disproportionate. All the bones are not short. Only the femur and the humerus are smaller. It is disproportionate. Clear? Okay. So there could be a bullet-like vertebra also is one of the features, but these are the more important one-liners in achondroplasia: champagne glass pelvis, trident hand, tombstone iliac blade, chevron-like epiphysis, rhizomelia. Okay. And just to cover more ground, there is another lethal cause of dwarfism, which is called as thanatophoric dwarfism. Another lethal cause of dwarfism, which is called as thanatophoric dwarfism. It has two MCQs which the examiners like to ask. Long bones are bored like telephone handles. So telephone handle long bones and H-shaped vertebra are seen in thanatophoric dwarfism. Thanatophoric dwarfism. Telephone handle long bones, H-shaped vertebra. Okay. Now, because you have to understand, beta, achondroplasia is a problem of enchondral ossification. So the bones will have some abnormal shape. Iliac blades, instead of being rounded, will be more square, just like how the tombstone looks like. I will explain to you, beta. What is tombstone? I will explain to you. Tombstone matlab aisa. This is your sacrum. These are your ilium. In achondroplasia, the ilium are more square, just like the tombstone. And what is written on these tombstones? Let us see. Okay, let me zoom it and see it. There's something written on the tombstone of this person. What is the most important two words that should be written on a tombstone? Anybody? No regrets. The most important decision should be that you should have no regrets. After 10 years, 20 years, you will not regret getting a little late today in the class, but you will regret if your rank is not good. So it is important to have no regrets in life. Do everything that will, help you to have no regrets. Okay. Some bacha is saying rest in peace. That is what other people will tweet after the event happens. But for you, most important should be no regrets. Thanatophoric dwarfism will lead to bored long bones like the handle of the older telephones and H-shaped vertebra. Clear, everybody? Everybody? And what is chevron? Chevron is, I'm sure some of you might have seen it already. If you see on the road you will see a symbol like this. Have you seen on the roads they have marked, whenever there is a road curving, they have marked like this. This is chevron. So epiphysis shaped like a triangle is called a chevron-like epiphysis, which happens in achondroplasia. Okay. Now I'm repeating. H-shaped vertebra are seen in sickle cell anemia as well as achondroplasia, as well as thanatophoric dwarfism. Now let's go further. Now I think we have discussed enough miscellaneous when the child was asking. Now my question to you is, what will happen in vitamin C deficiency? vitamin C is required for collagen. Okay, and collagen is required for osteoid formation. Osteoid is formed, then it is mineralized. So my question is, let us start with scurvy now. We were looking at different bone dysplasias and rickets, but my question on scurvy is, if you don't have collagen, what will happen? Osteoid will not be formed properly. Mineralization will be okay because mineralization is dependent on vitamin D. The osteoid formation is dependent on vitamin C. Clear? Okay. Okay, so this is going to determine what we see in the image. Now let us try to understand what will happen in scurvy, and I will label the image that we have on the image book side by side. Okay, now first thing, in scurvy, because the osteoid is less, the bones which are formed will be very thin. In scurvy, the bones which are formed will be very, very thin bones. Okay, we will call it pencil thin cortex. Okay, because the material is not there, the material is forming less, the collagen is less, so there will be pencil thin cortex. Not only the cortex of the bone, even the, everybody understand, even your epiphysis will have a prominent border. There will be only a prominent margin to the epiphysis. Okay, I will explain better. एक बार दोबारा सुनो. Entire bone will be very, very thin. So all you will see in the bone will be the thin pencil-like cortices, and only the margin of the epiphysis will be visible. Rest of the part will be very thin. You will not see in the center. You will only see periphery of the epiphysis. This is called as Wimberger, after the name of the person, ring. This is called as Wimberger ring. I am repeating. In scurvy, listen to me all of you, in scurvy, because the collagen is less, the problem is in the collagen cross-linking, the bone will be thin, only the pencil thin cortical margins will be seen, only the margin of epiphysis will be seen, which is called as Wimberger's ring. Okay. Now what will happen at the provisional zone of calcification? At the provisional zone, the osteoid will be less, but mineralization will happen at the normal pace, because mineralization is dependent on vitamin D. I want all of you to listen to me. It's little bit complicated, but we can do it because I know you are all bright children. I'm sure you can pick it up. है ना? एक बार सोचो. Suppose the osteoid is less. Everybody, wake up. It's good morning. Okay. If osteoid is less, but mineralization is happening at the fast pace that normally happens because vitamin D is saying mineralize karo, then what will happen? Anybody tell me? If mineralization is happening at normal speed but osteoid is less, the same osteoid will again and again get mineralized. So this provisional zone will become dense. You will have a dense provisional zone of calcification, which is called as white line of Frankel. Okay, I think Shubham Manoj got it right. That ulta hai, rickets se ekdam reverse ho gaya. This is reverse of rickets. In rickets, the provisional zone of calcification was lost. In scurvy, it becomes more dense, which is called as white line of Frankel. है ना? Osteoid is the ground substance. Sai Kiran Bomana. Osteoid is the ground substance, and to form the bone, it needs to have mineral in it. है ना? So osteoid formation needs collagen. Mineralization needs vitamin D. Okay. Now my question to you is this. So white line of Frankel is seen in scurvy. Another thing that will happen is, just distal to the white line of Frankel, I have made a zone where the mature bone was supposed to be formed. The bone, the blood vessels, they had to be formed, But because of lack of collagen, this area becomes weak. And because of weakness, it breaks. So this area breaks and becomes dark, which is called as Trummer Feld, or we can use the term scorbutic zone. Okay, dense PZ is provisional zone. Aksa Nayab is provisional zone. Beta, provisional zone. Are you clear? Okay. Now somebody saying, sir, what to mark? Neil Rathod. है ना, मैं बता रहा हूँ बेटा. देखो सुनो. If they say white line of Frankel is seen in scurvy rickets, answer is scurvy. But if they say scurvy healing rickets, then answer is both. Okay. Rickets नहीं, healing rickets है यहाँ पे, है ना? ठीक है? Clear? I'm again repeating. Right next to the provisional zone, you have an area where the final maturation of bone happens, which is not going to happen properly in scurvy because the blood vessels also need collagen, the bone also needs collagen. So this area becomes weak and it breaks. This break that happens here is called as Trummerfeld zone or scorbutic zone. There will be subperiosteal hemorrhages. There will be subperiosteal hemorrhages which will cause elevation of the periosteum. Subperiosteal hemorrhages, because in scurvy the capillaries will become fragile. In scurvy the capillaries will become fragile. You will have subperiosteal hemorrhages, and because of the periosteum getting elevated, you will see overgrowth of the metaphysis till the periosteum. This overgrowth, this bony spur that forms between the periosteum and the metaphysis is called as Pelkan spur. Okay. Now let us see it with an X-ray example so that we are able to revise it again. So this is an image, previous NEET PG question. I have removed the labeling so that we can label it together. So this is a schematic diagram showing you the X-ray findings of scurvy. First of all, I want you to see the first part. What is this first part denoting? Subperiosteal hemorrhage. Okay. What is this? Subperiosteal hemorrhage. Number two, everybody see with me. Can you see that there is a dark zone here? I will try to zoom it further. Provisional zone is more white. Just next to the provisional zone, there is a insufficiency fracture which has happened because of lack of proper bone formation in scurvy. So this area is called as the Trummerfeld zone, or we say scorbutic zone, and the dense white area is called as white line of Frankel. Only the margins of the epiphysis are seen, that is called as Wimberger ring, and the bony outgrowth between the metaphysis and the periosteum that you see here is called as Pelkan spur. Okay, so sometimes they ask you all this as one-liners or as an image. Scurvy is a frequently asked image-based question or a one-liner. So keep it in mind. For example, you know, some of you might have seen the FMG screening papers that we have already given to you in your PPE kit. They repeat scurvy very often as a question. So I'm again repeating for all of you. Scurvy leads to problem in collagen. So bones are thin, pencil thin cortex. Only the margin of the epiphysis is visible, that is called as Wimberger's ring. The provisional zone of calcification becomes more dense because the osteoid is less, but mineralization is happening at the correct pace. White line of Frankel. Right next to white line of Frankel, we have a zone where the bone has become weak. There is, because collagen is required for the blood vessels, it is required for the bone formation. This area remains weak and breaks. This is called as Trummerfeld zone. You have subperiosteal hemorrhages. The metaphysis overgrows between the bone and the periosteum and forms a spur which is called as Pelkan spur. Okay. So white line of Frankel, Shobit Pal is seen in, it is seen in, anybody? It is seen in scurvy and healing rickets, not in rickets. Okay, so this was about scurvy. Then how will we get confused in the exam? In scurvy, in the bone you have subperiosteal hemorrhages, but suppose if they say hemarthrosis, then अब बताओ, देखो, now scurvy में because the capillaries become fragile because of lack of collagen, they bleed and you have subperiosteal hemorrhage. But if you have a problem in the clotting factors like hemophilia, so in hemophilia you will have hemarthrosis. That means in hemophilia you will have bleeding in the joint. Okay, hemarthrosis, you will have bleeding in the joint. Everybody understands? So what happens is, a simple question sometimes they might ask you, suppose if this is your femur and the knee joint, knee is the place where you have, knee is the joint where you have hemarthrosis, often in hemophilia. If you have repeated bleeding in the joint, if you have repeated bleeding in the joint, again and again it is happening, it causes erosion of the intercondylar notch. Repeated bleeding in the knee joint causes the intercondylar notch to become deep. So sometimes they might directly ask you this question. A young adult comes to you with deep intercondylar notch on the x-ray, the answer will be hemophilia. So don't get confused. देखो, हड्डी में bleeding हुई, दो बातें हो सकती, scurvy subperiosteal करेगा and hemophilia में joint में bleeding होगा. Hemophilia will lead to hemarthrosis, which will lead to deep intercondylar notch. Now what was Pelton's spur? I think Aksa Nayab is again and again asking. देखो, metaphysis को देखो बेटा, Aksa, can you see this area and can you see this overgrowth? हड्डी के बियॉन्ड आ गया ना, स्पर की जैसा. दिस इज कॉल्ड एज पेल्कन स्पर. ओके, सो पेल्कन स्पर इज द ओवरग्रोथ. व्हाइट लाइन ऑफ फ्रैंकल तो यहां तक है, लेकिन वो हड्डी के बियॉन्ड आ गया तो उसको हम बेटा पेल्कन स्पर कह रहे हैं. अनमोल त्यागी, आप समझ आया है ना? देखो, ये है व्हाइट लाइन ऑफ फ्रैंकल, बट इफ इट ओवरग्रोस बियॉन्ड द बोन इट विल लुक्स लाइक अ स्पर. दिस स्पर इज कॉल्ड एज पेल्कन स्पर. ओके. Okay, so we saw scurvy and what is the difference between scurvy and hemarthrosis. Now let us give you some confusing questions. I will give you some confusing questions. Let's see how many of you can answer these confusers. Okay, confusing question दूंगा, आपने बताना है बेटा. Epiphyseal dysgenesis is a feature of. Now, what is epiphyseal dysgenesis? Epiphysis is not properly forming. It is not properly forming. So this is not seen, this is not rickets, this is a problem where epiphysis is not getting formed properly, and to form properly we need thyroid hormone. So epiphyseal dysgenesis is a feature of hypothyroidism. Epiphyseal dysgenesis is a feature of hypothyroidism. Can you name some other features of hypothyroidism? Delayed bone age, Vermian bones. Okay, anybody? Hypothyroidism leads to delayed bone age and leads to Vermian bones. Achondroplasia में क्या था? Chevron like epiphysis. But if they say dysgenesis, hypothyroidism, which will have delayed bone age, Vermian bones. Some of you might say, what is Vermian bone? Vermian bones are intrasutural skull bones. Prominent intrasutural skull bones. Skull के lambdoid suture में बहुत सारी bone हो. So prominent intrasutural skull bones typically seen in the lambdoid suture in patients with hypothyroidism. Chaitanya is saying, sir, scurvy में why is periosteum getting elevated? Because of bleeding below the periosteum, because capillaries are fragile if you have scurvy. Clear beta? Okay, now let us now go forward and try to look at some x-rays of arthritis. In arthritis, I want you to differentiate between these two: osteoarthritis, rheumatoid arthritis. Okay, now what will happen is when you become big famous doctor, and you will have some patients, some relatives coming to you and saying, okay, I have joint pain. Now there are two broad sets that we need to know. One is the usual osteoarthritis that happen in old people, wear and tear, and one is a inflammatory immune mediated disorder, rheumatoid arthritis, multi-system disorder, needs immune modulation. So we need to differentiate between them on a X-ray. Okay, we need to differentiate between them on a X-ray. I will explain to you how they look like. Okay, let's try to understand and let us go beyond. I think there are some questions. Some bachas have delayed bone age मतलब क्या होता है? Brahmi and Devanshi, bone age मतलब क्या होता है? देखो सोचो, whenever we see based on the epiphyseal closure that you see in the wrist and in the elbow, you can find the age of the patient when you look at the different bones and the carpal bones. You are able to guess the age looking at the skeleton. In hypothyroidism, the skeletal age will be less than the chronological age. Okay, now let's try to differentiate between the two. Osteoarthritis is wear and tear of the articular cartilage, wear and tear of the articular cartilage, while rheumatoid arthritis is inflammation of the synovium. Okay, rheumatoid arthritis is the inflammation of the synovium. Inflamed synovium can be called as pannus. Inflamed synovium in pathology is called as pannus. Now I will tell you one by one, and I want you to listen to me so that we are able to solve this question. Suppose this is your knee joint. Suppose this is your knee joint. Okay, in your knee joint, in any joint, lining the joint margin, in any joint, lining of the joint margin here is with a cartilage. You have cartilage here, hyaline cartilage sitting here. Okay, this hyaline cartilage is the articular cartilage which is forming your joint space. Okay, which is forming your joint space. Are you able to understand this? Yes. Okay, now tell me, in osteoarthritis what is happening is you will have wear and tear in the weight bearing compartment. So in your femur, in your knee joint, the medial compartment is weight bearing. So weight bearing compartment will have loss of articular cartilage. In the weight bearing compartment, the cartilage will be lost. So if the cartilage is lost on the X-ray, that space will reduce. So in osteoarthritis on X-ray you will see non-uniform loss of joint space. Very important MCQ. Anybody now tell me, in osteoarthritis you will have non-uniform loss of joint space. Tell me why. Non-uniform क्यों है? Because the joint space or the cartilage is getting lost more in the weight bearing compartment. Damage is more in the weight bearing compartment. Are you clear? Are you able to understand? And now because when this the joint space is asymmetrically lost, what will happen? You will have some on the margin of the joint, you will see some overgrowth of the bone. You will see some horizontal spurs forming at the margin of the joint, which are called as osteophytes. Which are called as osteophytes. Are you able to understand? So in which condition do we see osteophytes? Osteoarthritis. These are horizontal spurs developing from the joint margin. Further, what will happen is, because now the bone, the articular surface of the bone is not protected by cartilage, cartilage is lost. So again and again, when the bone hits against the bone, the trabeculae get compressed and they develop sclerosis. You will develop subchondral sclerosis. Some of those bone pieces, when the bone is hitting against the bone, some of those pieces might break and can cause loose bodies. Okay, I am again repeating for all of you. Tell me, what are the X-ray features of osteoarthritis? non-uniform loss of joint space, non-uniform loss of joint space, osteophyte formation, subchondral sclerosis, loose body formation. Okay, clear? Now, let us look at our X-ray first, then we will go to rheumatoid arthritis. Let us see the X-ray first so that we are able to solve the question. Okay, just give me 1 second. Let me load the X-ray for you. Now, please see with me. Now, I want all of you to look at this X-ray of the knee joint and tell me. Okay, I will explain to you Anamika Singh also, but look at this X-ray and tell me, look at this joint space and tell me what has happened. Look at this joint space and tell me what has happened. There is loss of medial compartment joint space. Lateral is preserved, so there is non-uniform loss of joint space, osteoarthritis. And because the bone is hitting against the bone again and again, the trabeculae gets compressed and they become more dense, they appear more dense, subchondral sclerosis. And if the bone is hitting against the bone and a piece breaks, you form loose bodies. Are you clear? So what is this? Osteoarthritis, because there is clearly non-uniform loss of joint space. Okay, the joint space is lost but only in the weight bearing compartment. Think of osteoarthritis. Are you clear, beta? Now, if you are clear with this, let us look at rheumatoid arthritis. Rheumatoid arthritis, on the other hand, is an inflammatory condition. Rheumatoid arthritis is an inflammatory condition. Okay. Now what will happen is, if this is your bone, I want all of you to understand. Typically, the changes will be seen in the metacarpophalangeal, proximal interphalangeal joint in rheumatoid arthritis. So suppose this is a joint, these are your cartilage. In rheumatoid arthritis, the synovium will be inflamed. The synovium is the lining of the joint that will be inflamed. If the synovium is inflamed, any one of you can answer. What will happen in inflammation? You have hyperemia. What is hyperemia? Increased blood flow. Okay, everybody listen to me. I will tell you when to take a break. Don't worry. Hai na? I think Namra is saying I want water. You can, carry your phone and go to the fridge and have water. Okay. My question is now, tell me. Now suppose if you have inflammation around the joint, you will have increased blood flow in the inflammation, because inflammation leads to hyperemia. If there is increased blood flow, any one of you can answer. Increased blood flow, it will remove the calcium from the bone. It will cause demineralization. Hyperemia leads to demineralization. That means what will happen? You will develop periarticular osteoporosis. First X-ray sign of rheumatoid arthritis is periarticular osteoporosis. This will not happen in osteoarthritis. Osteoarthritis के अंदर we had subchondral sclerosis. In rheumatoid arthritis, because it is an inflammatory condition, you will develop periarticular osteoporosis. Okay, on the X-ray. Then what will happen? Wherever your inflamed synovium is touching the bone, you will develop localized destruction. These localized destructions are called as erosions. I am repeating for all of you. Wherever the inflamed synovium is touching the bone, you will develop erosion. This erosion is typically seen in the part within the joint which is not covered by cartilage first. These are called as bare area erosions. That means part of the bone which is within the joint but not covered by cartilage is called as bare area. You will see bare area erosion. Periarticular, juxtaarticular almost means the same thing, Yashi. Okay, now tell me beta. So periarticular osteoporosis followed by erosions, and these are the things we never saw in wear and tear disorder. We are seeing them in inflammatory condition. Now what will happen is, I want you to all listen to me. Otherwise, we'll not be able to form the concepts that we want to form. In inflammation, the cartilage will be destroyed by inflammation, not by the wear and tear. By inflammation, the cartilage will be destroyed. If inflammation causes destruction of cartilage, you will have uniform loss of joint space. In rheumatoid arthritis, it leads to uniform loss of joint space because of inflammatory destruction of the cartilage. Clear? Now some बच्चा मुस्कान एंड साक्षी सिंह से हाइप्रीमिया से ओस्टियोपोरोसिस कैसे हो गया? अभी मैंने बताया था ना पहले भी, हड्डी में bone and the blood calcium are in homeostasis. Bone is producing mineral, blood vessels are taking it away. So if you have more blood flow, it will take more mineral away from the bone. That is why if you have inflammation, it causes osteoporosis of the bone. So you will have uniform loss of joint space because this is not wear and tear, this is inflammatory destruction of cartilage. Then you will have dislocations and deformities. And you will study about this more in your orthopedics and rheumatology. Swan neck deformity, boutonniere deformity, like this. So deformities will happen later in the course of disease. Earlier you will have periarticular osteoporosis, erosions, uniform loss of joint space, dislocation, deformities. Okay. Erosions happen wherever the inflamed tissue is touching the bone, that part gets eaten up. I will show it to you with an image and then we will discuss. Let's look at an image and then try to discuss. Let us see the X-ray first. Now tell me, what X-ray? We are looking at X-ray of both hands and wrist. Why both? Because we are dealing with a systemic process. It should affect both the hands. And I want you to look at the metacarpophalangeal joints. Metacarpophalangeal joints. MCP, 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 MCP. What do you see? Osteoporosis. I will zoom it. At the end of the metacarpophalangeal joint, surrounding the joint, you will see area of reduced density. This is periarticular osteoporosis. Periarticular osteoporosis. And I also want you to see, let me try to zoom the image. I want you to see this area now. Okay. Try to see the area that is now marked with the arrow. Can you see? This is the articular margin. At the periphery, you have an area within the joint not covered by cartilage called as the bare area. You can see the bare area will look eaten up. This is called as erosion. Bare area erosions typically seen in rheumatoid arthritis. Rheumatoid arthritis. And you can also see the carpal bones here. I think Himaja Chirasini, please see. Uniform loss of joint space मतलब दोनों compartment, सारे compartment loss हो जाएंगे. जैसे यहाँ पे देखो, between the carpal bones, you cannot appreciate any joint space. The joint space is uniformly lost. In osteoarthritis, the joint space loss is non-uniform. It is more in the weight-bearing compartments. Okay, everybody follows? Now, let me ask you some tricky questions now. I will ask you some conceptual questions now. Conceptual questions. Let's see if you can answer. Okay, conceptual question. In the exam, they will give you a question like this. What is the earliest X-ray feature of tubercular arthritis? Now, TB will be different from rheumatoid because rheumatoid is a systemic disease. It will be symmetrical. Tuberculosis will be asymmetrical. It's an infection. Rheumatoid arthritis is a immune disorder. Now, anybody can answer this question. Okay. Can anybody tell me what will you see earliest in tubercular arthritis? Now, what is tuberculosis? Tuberculosis is an inflammatory process. So, inflammation will cause hyperemia. Hyperemia will cause periarticular osteoporosis. So, even tuberculosis of the joint, the first X-ray feature is periarticular osteoporosis. Okay, everybody follows? And then it will also have these are the, it will also develop erosions because inflammatory diseases lead to erosions. And then there will be loss of joint space. Now anybody tell me, in TB the joint space is getting lost because of inflammatory destruction of cartilage. Inflammation के कारण जब cartilage खत्म हो रहा है तो पूरे के पूरा खत्म होगा. It will not be only at the weight bearing compartment, it will affect the entire cartilage. So you will see uniform loss of joint space. So how will you identify tubercular arthritis? Periarticular osteoporosis, erosions, loss of joint space. How will you differentiate from rheumatoid? Rheumatoid will be symmetric, this is asymmetric. What is this called as? This is called as Pfeiffer's triad of tubercular arthritis. This is called as Pfeiffer's triad of tubercular arthritis. Name of the person who described it. So it is interesting to note that once we understand the concept, we are able to apply it. I will show you one more example. This is a quiz for you. It is not there in your image book. I thought I will make a quiz for you, special quiz. Anybody can look at the image and answer. Now I want you to look at this hand X-ray. It looks deformed. There is some deformity at the metacarpophalangeal joint. The hand is like this. There is deformity. Okay. This is very difficult question, beta. Okay, very difficult question. This is deformity. Anybody can tell me, is this rheumatoid arthritis or not? There is deformity at the MCP. And deformity is seen in, and your rheumatoid arthritis, very typical. It could be, you can have such a deformity in rheumatoid arthritis, but is this rheumatoid arthritis or not? The answer is no, this is not rheumatoid arthritis. I will show it to you. This is very tricky and you will learn it later on when you read medicine and your orthopedics. Please see the joints. Please see the metacarpophalangeal joints. The joint space is preserved. There are no erosions. There are no destruction of the joint. So there is no erosion. Only deformity is visible. That means the deformity is not happening because of the joint getting destroyed. It is probably because of the tendon and muscles having some kind of disease causing that deformity. So if you see deformity but no erosion, okay, the key word is here, deformity but no erosion. Think of lupus, SLE, or think of a kind of arthropathy called as Jacquard's arthropathy. Clear? Are you able to understand this? So if you see deformity but no erosions, think of SLE and Jacquard's arthropathy, which is again a potential MCQ for you. And just to make it slightly more, interesting for you, slightly more tough for you, let me add a line here. Let's see if you can answer. Suppose you see a X-ray of a patient. Okay, I will ask you a question, then you will have to answer, beta. I want all of you to answer, beta. Don't look here and there, just look at the question. Suppose you have a patient with joint pain and the X-ray shows increased density around the joint, some debris in the joint, dislocations in the joint, disorganization of the joint, distension of the joint. Okay, now everybody now look at this X-ray features and tell me. X-ray shows increased density, debris, dislocation, disorganization, distension. I want all of you to see and tell me, if there is increased density around the joint margin, is this inflammatory or wear and tear? एक बार बताओ मुझे, if there is increased density, is it inflammatory or wear and tear? Inflammation में क्या होगा? Inflammation leads to osteoporosis. If there is increased density, it means there is wear and tear. Debris, wear and tear. Remember, in wear and tear, if the bone hits the bone, you develop loose bodies in the joint. So first 2 points are telling you there is wear and tear. But if there is dislocation of the joint, disorganization of the joint, that means there is too much wear and tear. That means the joint is having so much wear and tear that it has gotten dislocated, it is swollen, it is disorganized. Now the question is, why would you have exaggerated wear and tear of the joint? You will have exaggerated wear and tear if there is repeated trauma to the joint. Okay, you will have exaggerated wear and tear if you have repeated trauma to the joint. But my question to you is, all of you, please tell me, if this patient is having repeated trauma to his joint, why is he not saving himself? बार बार चोट लग रही थी तो बचा लेना था ना. Why is he not saving himself? Because he has no sensation. This is the X-ray feature of neuropathic or Charcot arthropathy, Charcot joint. Are you able to understand this? This is what happens in diabetic patients. In diabetics, now this is what is happening in diabetics. In diabetic patients, because you don't have sensation, you tend to cause repeated damage to your joints, and the joints become dense with debris, dislocation, disorganization, which is called as Charcot joint. Now, I have explained to you what is Charcot joint. Now, what is happening is, today in the world, what is happening is, it becomes very easy if I, instead of explaining to you, if I tell you like this, देखो बच्चों, Charcot joint में you will have 5D. Density, debris, dislocation, disorganization, distension. Okay. So it becomes very easy if I tell you 5D, remember mug up, okay. So the children will do like this, 5D, D for Dicky, D for D, A for apple, B for Y. And what he's doing is only rote learning, mugging up, and nothing is going into his brain, and he's getting frustrated. Why did I become a doctor only to do D for donkey, D for dog, A for apple? So that is what I have against the mnemonics. Although sometimes they might be handy, but important to remember that what is happening, why it is happening. If you don't have sensations because of the diabetes or syphilis, the joint will have more damage because you're exposing it to repeated trauma. Everybody understands? Now I'll show it to you how it looks like. Now this is a X-ray which I wanted you to see, and if you want to take a picture, you can take it here. You can see the joint is having increased density. There are some loose bodies, and the joint is totally dislocated. You can see there is the congruence between the two bones is lost. So a totally dislocated joint with increased density, with loose bodies, think of Charcot joint. So you can remember Charcot joint as exaggerated wear and tear changes in the joint. Exaggerated wear and tear changes in the joint will be called as, everybody, are you clear? Charcot joint is, anybody, can you tell me? Neuropathic joints. In which condition? Diabetes mellitus. Everybody understands? Okay. Now, just one more point, and maybe then we can consider going on a break. Suppose you have a seronegative disease which is seen in children affecting the knee joint. Seronegative means rheumatoid factor is negative, involving the knee joint, listen to me, called as juvenile rheumatoid arthritis. What will you see on the X-ray? What will you see on the X-ray? Anybody? What will you see on the X-ray in juvenile rheumatoid arthritis? Here again there will be inflammation around the knee joint. Inflammation around the knee joint. Inflammation will lead to hyperemia, increased blood flow. Okay. My question is this, beta. Let's see if you can answer. Anybody of you can answer in the chat box. Okay. अभी बाकियों को मत देखो, अपना आंसर बताना, ठीक है? Tell me, if you have increased blood flow in the joint where the epiphysis is still growing, it's a child, epiphysis is still growing, and you are having inflammation causing increased blood flow, what will happen? Increased blood flow will lead to enlarged epiphysis. So which condition leads to enlargement of epiphysis? Juvenile rheumatoid arthritis. Why it does not happen in adult? Because adult में वो grow हो चुका है. In children, the epiphysis is still growing. If it gets inflamed at that time, it overgrows. Enlarged epiphysis are a feature of juvenile rheumatoid arthritis. Everybody clear? Everybody clear? Okay. Now I think we can take a small break. When you come back, I'll show you seronegative. We have started seronegative. I'll show you how we'll look at ankylosing spondylitis and other different spine conditions. We will do them, and then we'll go on to the ultrasound and IVPs. So I think we even osteoporosis will happen. Correct. Rahul has said even osteoporosis will happen, but in children the peculiar feature will be enlargement of epiphysis in the knee joint is seen in juvenile rheumatoid arthritis. Okay, clear? Okay, so we can take quickly a 10 minutes break if that is okay with you. A 10 minutes break like some of you were asking, and please come back in 10 minutes and then we'll go forward and talk about other conditions. And some bachches are saying JRA. JRA matlab juvenile rheumatoid arthritis beta. Juvenile rheumatoid arthritis. Okay. Again, it will also show Anmol Tyagi. Even it will also show demineralization भी होगा and ला दोनों होगी चीजें. Okay. Okay. So let's be back in 10 minutes. I'll try to be back in 10 minutes, and maybe 1 or 2 minutes we will entertain you and then we'll start. Okay. Okay, everyone. So welcome back after the break, and jhukega nahi, and we'll work hard and keep winning the game. So what we've done now is, I hope you understood the way I have built up things. I've tried to put the conceptual X-ray things for you in bones. I've talked about tumors. It was difficult topic. You were reluctant, but I still went on. I covered the ground because I wanted to make sure that I cover bone tumors. Then I covered the infective processes on X-ray, how to identify, went on to metabolic disease, rickets, scurvy, hyperparathyroidism, osteomalacia, etc. Then we looked at arthritis, osteoarthritis, rheumatoid arthritis, tubercular arthritis, diabetic Charcot joint, SLE, and I showed you the logic and the differences between them. Okay. Now what I will do is I will show you a special type of arthritis which is seronegative. That means the rheumatoid factor is negative, HLA-B27 positive, spondyloarthropathy or spondyloarthritis, involves the spine and the joint. What do you think? What am I talking about? Ankylosing spondylitis. Now, one of the favorite X-rays in our exams is ankylosing spondylitis. They love to ask the ankylosing spondylitis. I will show you some one-liners, some visuals on ankspons, and some differential diagnosis. Okay. First question, beta. Anybody answer this first question for me, beta? I am sure you can answer this. Okay. What is the earliest X-ray feature of ankylosing spondylitis? What is the earliest X-ray feature of ankylosing spondylitis? Anybody? Now, ankylosing spondylitis, what will happen is, okay, ankylosing spondylitis begins with sacroiliitis. So what is happening in the disease is, initially you will see symmetric sacroiliitis. On the X-ray, the first finding will be blurring of the subchondral cortex on the iliac side of SI joint. I'm again repeating. This is NEET PG 2019 MCQ. They've asked, what is the earliest X-ray feature of ankylosing spondylitis? The answer is blurring of the subchondral cortex on the iliac side of the SI joint. Okay, that means sacroiliac joint has two sides. It has a side on the sacral side, iliac side. The X-ray changes are first seen on the iliac side, which is a very important MCQ. But even more important is, this sacroiliitis is first appreciated on MRI, not on X-ray. So if they ask you what is the investigation of choice to pick up sacroiliitis or to diagnose ankylosing spondylitis early, MRI should be done. And I'm sure many of you might have seen this in clinical practice also. If we are suspecting sacroiliitis, we do not advise X-ray, we actually advise MRI now, because MRI can show me bone marrow edema, it can show me the inflammation around the joint. Are you clear, beta? Okay, so ankylosing spondylitis, we should do MRI to look for symmetrical sacroiliitis. MRI is the investigation of choice. X-ray earliest finding is loss of subchondral cortex on the iliac side of SI joint. Okay. Now what will happen on SI joint? Let me explain to you. Suppose this is your sacrum and suppose this is your ilium. Okay. So that means we are looking at the sacroiliac joint. In ankylosing spondylitis, what happens is that because of inflammation, the joint starts to get destroyed, the lower part of the joint, you start seeing some destruction. This is called as erosions. So first you will see blurring of the cortex, then you will develop erosions. Now ankylosing spondylitis is a subacute process. Ankylosing spondylitis is not as destructive as rheumatoid arthritis was. It is more of subacute process. So what will happen is, along with the erosions, you will also have some sclerosis happening. Erosions plus adjoining sclerosis. Always remember, in rheumatoid we had only erosions, while in ankylosing spondylitis you also develop adjoining sclerosis. Second thing to remember is, rheumatoid was involving the hand joints, remember, MCP, PIP, while ankylosing spondylitis is more in the axial skeleton. It is involving the SI joint, involving the spine. I will explain. Okay. So remember, it is symmetric, Yas, it is symmetric on both the sides. That means both SI joints will be involved, but within the SI joint, the damage is first seen on the iliac side. Okay. Now anybody, now because of these erosions that are happening here, the joint will appear, the joint space will appear to you as widened. So although the joint itself is not widened, it is actually destroyed. It is called as pseudo widening of SI joint. So in which condition do we have pseudo widening of SI joint? Ankylosing spondylitis, and ultimately it leads to fusion of SI joint or ankylosis. Okay, so I'm again repeating. Ankylosing spondylitis begins with sacroiliitis, first appreciated on MRI, then on X-ray you will see blurring of the subchondral cortex on the iliac side, followed by erosions and sclerosis, pseudo widening on SI joint, and fusion of SI joint. This is what will happen on the X-ray. Clear? Okay. Now in the sacroiliac joint, what will happen in the spine? To understand what will happen in the spine, we need to understand a word called as enthesitis. Enthesitis. What is enthesitis? Inflammation of the enthesis. What is enthesis? Enthesis is the insertion site of a ligament or tendon on the bone. Okay. एंकाइलोसिस मतलब फ्यूज हो जाएगा, बीमारी पुरानी हो जाएगी ना, जॉइंट जुड़ जाएगा, दैट इज एंकाइलोसिस और फ्यूजन, दीक्षा. ओके, आई एम अगेन रिपीटिंग. I hope you understand बेटा. So ankylosing spondylitis, look at the name, ankylose करने वाली spine की inflammation. Ankylosing spondylitis, the name itself is telling the ultimately the joint will become fused. So it begins as an acute inflammation, erosion, then subacute process destruction, then ultimately it becomes fused. Okay. So any fusion will always be a later thing that will happen. Okay, clear beta? Now my question is, any site of the bone where a tendon or ligament is inserting is called as enthesis. Enthesitis is inflammation. Now look at what will happen in the spine. It is slightly difficult, so I want your full attention. If these are your vertebra, in between the vertebra you have the disc. The central part of the disc is nucleus pulposus, and peripherally you have annulus fibers. Okay. Now I want all of you to hear me for 1 second. Just hear me for 1 second so that I don't have to repeat again. Just hear me for 1 second. The outer disc fibers are inserted in the corner of the vertebra. Outer disc fibers are inserted in the corner of the vertebra. That means vertebral corner is a enthesis. It will get inflamed. So in ankylosing spondylitis, when the enthesis gets inflamed, the vertebral corners, the corner of the vertebra show erosion. This is called as, after the person who described it, Romanus lesions. Okay. Are you able to remember? Should I repeat? In ankylosing spondylitis, you will have enthesitis. So at the site of insertion of the disc fibers in the corner, you will see erosions called as Romanus lesions. But these erosions will also have accompanying sclerosis. These erosions will also have accompanying sclerosis. Tell me why? Because ankylosing spondylitis is a subacute process. You will have accompanying sclerosis also, which is called as shiny corner, shiny corner sign. So ankylosing spondylitis, you will start to see in the spine corner changes because of enthesitis. The corner will have erosion, it will be more sclerosed. So you will see Romanus lesion and shiny corner sign. Okay. Then what will happen is, as the disease will become more and more progressing, this area wherever you have inflammation, now it will start to heal with some ossification. Now what will happen is, as the disease will progress, between the two corners you will start to see ossification. Between the two corners you will see vertical bars which are connecting the two corners, which will be called as syndesmophytes. Syndesmophytes. And not only that, even between our spinous processes, you have interspinous ligament. At the spinous process you will have inflammation of the enthesis, then the interspinous ligament will also get ossified. So you will see ossification of the interspinous ligament, which is called as dagger sign, while the syndesmophytes are called as the bamboo sign. So you can again, now if you appreciate this, syndesmophytes are vertically oriented, osteophytes were horizontally oriented. I hope you see the logic behind. Are you able to understand? Again, Sanskriti and all, I am repeating again. So what I'm trying to do is, I'm trying to give you the why behind what is happening. Okay, I'm repeating once. I want all of you to listen to me. Ankylosing spondylitis, it will begin with sacroiliitis. Sacroiliitis will be seen on MRI. Then you will see X-ray changes on the iliac side first, although it will be on symmetrical on both sides, but more on the iliac side. Then you will see erosions, adjoining sclerosis with pseudo widening of the SI joint. And in the old, when the disease becomes more chronic, the SI joint will ankylose, it will fuse. In the vertebra, because of enthesitis, you will see erosion at the vertebral corners, which is called as Romanus lesion. It is a subacute disease, so destruction and healing will occur together. You will see sclerosis called as shiny corner sign. And when the disease progresses, your outer disc fibers will ossify, they will become calcified, they will become syndesmophytes, bamboo spine, interspinous ligament will also become calcified and white on the X-ray, it is called as dagger sign. How it looks like? Let us try to see it first before we talk about it more. Let us try to see it first. I'm sure many of you can understand this. This is a typical exam image. I am sure that many of you can look at these arrows and tell me what are these. Can you appreciate bony bridge joining the two corners, syndesmophyte, and the spine is looking like a bamboo. What is your answer? Bamboo spine, bamboo spine. Okay. And also see that the interspinous ligament is also ossified, that is called as the dagger sign. So we have the bamboo spine appearance and the dagger spine appearance. Are you clear? So ossification of the interspinous ligament is called as the dagger sign. If you look at ankylosing spondylitis on the lateral view, if you look at the ankylosing spondylitis on the lateral view of the spine, in the lateral view, I am sure you can appreciate two things. Can you see there is a vertical bridge? Can you see? There is a syndesmophyte connecting the disc, connecting the two corners of the vertebra. Again telling you that this is a syndesmophyte. Syndesmophytes represent ossification of the outer disc fibers. And also in ankylosing spondylitis, the vertebra appear square in shape. Because of the erosion of the vertebral corners, they appear more squarish in shape. Squaring of vertebra, syndesmophyte formation. What do you think we are looking at? Ankylosing spondylitis. Now this ankylosing spondylitis leads to a spine which is more stiff. Okay, a spine which is more stiff. So what is the risk of a stiff spine? Anybody? If the vertebrae are all joined together, the spine becomes stiff. What is the problem with stiffness? So we know by now, if something is very stiff, it cannot bend. If you try to bend it, it breaks. So ankylosing spondylitis, the risk is that the spine fractures easily. Okay. In the ankylosing spondylitis, the spine fractures easily and it can lead to a fracture of the end vertebra in the spine, which is called as carrot stick fracture. Just like a carrot, if you break the carrot, it totally breaks. Similarly, in ankylosing spondylitis, the patient can have a spinal fracture. And risk of a spinal or a vertebral fracture is that it can lead to cord compression. So that is why we need to be very careful that ankylosing spondylitis, the spine becomes stiff and fractures easily. Okay, and I think Janvi Rai and Somik got the idea that it was breaking easily. Very good, beta. Are you clear? Now, can you name any other condition which is similar to this, which causes stiffness of the spine? Now, I want you to look at another condition. This is out of the syllabus of undergraduate education, but it is asked in your AIMS exam, INI CET exam. Let's see. I want you to look at this area. Okay, can you see anterior to this cervical vertebra? Can you see there is a thick wax-like bone formation over the anterior longitudinal ligament? So if you see ossification along the anterior longitudinal ligament, which is thick and looking like flowing wax, what will you suspect? Anybody now? Okay, anybody now? Can you answer? Can you now think of it and tell me if the, this is not ankylosing spondylitis. Ankylosing spondylitis में disc के outer fiber ossify हो रहे हैं. Ankylosing spondylitis में it is the outer fiber of the disc which are getting ossified. Here it is the anterior longitudinal ligament which is wax-like and ossified. What do you think? This condition is called as, now many MBBS students may not have heard of it, but they are asking this in AIMS. It is called as DISH. What it is called as DISH. What is DISH? Diffuse idiopathic skeletal hyperosteosis. What is this? Diffuse idiopathic skeletal hyperosteosis, also called as Forestier's disease. What will the X-ray show? Ossification of the anterior longitudinal ligament in the flowing wax appearance. It is a non-inflammatory condition. SI joint in this condition are normal. There is no sacroiliitis. SI joints are normal. Thoracic spine is the most common area involved. And in the thoracic spine, right side is involved more than the left side. These are the typical one-liners that you need to know. I will repeat. Forestier's disease is an important differential diagnosis. So keep it in mind. Keep it in mind if in the exam they say that there is ossification of the anterior longitudinal ligament, but if they say SI joint is normal, SI joint normal है, तो वो ankylosing spondylitis नहीं है. Okay, then go for DISH as the answer. What is DISH? Forestier's disease, non-inflammatory, SI joint is normal, most common part of the spine involved, thoracic spine, most common side involved, right. Everybody understands? Okay. Third thing that I wanted you to differentiate before I go onwards is this. Now I will tell you what is central institutes. When you go and give the exams of INICET, which is Institutes of National Importance, they want to ask and see how you are able to integrate your basic sciences and clinical sciences. So in this particular case, if I increase the size, these are the discs. These are the disc of this patient. Okay. Can you see the disc in this patient is appearing very white because the disc is calcified. So this patient has intervertebral disc calcification. Okay. Intervertebral disc calcification. Okay. Some bacha is saying why does DISH occur? I told you na naam bataya to tha diffuse idiopathic. We don't know why it happened. Idiopathic. Okay. Now some bacha is saying why is right side involved more? So Sakshi, there is a hypothesis ke thorax ke andar left side pe there is aorta pulsating. So the ossification happens in the thorax more on the right side because left side aortic pulsations are not allowing it to happen. That is the logic. Okay. Okay, beta. Now anybody tell me intervertebral disc calcification is seen in. So man, everybody thinking maybe it's a clinical question while it's a biochemistry question. Intervertebral disc calcification happens in alkaptonuria, or they will say ochronosis. And you will see when you go back to your biochemistry, they will say in ochronosis, alkaptonuria, homogenistic oxidase. Remember the cartilage, ear cartilage, nose cartilage, disc cartilage, they get calcified. So this is how they frame questions in AIMS exam. They will say IV disc is calcified. Look at this X-ray. This is the X-ray which was there in the previous AIMS exam, and everybody thought कि bamboo होगा. Bamboo नहीं है, ये disc calcification है. Disc calcification is seen in alkaptonuria, ochronosis. Clear? Now, but they did not mention the other findings, so we had to diagnose on the basis of X-ray. Now, what else can happen in the joint which is important for us to remember? Can you look at this X-ray and tell me which joint is involved? First metatarsophalangeal joint. Around the first metatarsophalangeal joint, you can see there is some soft tissue here. There is some soft tissue here, which is your uric acid tophi. Tophaceous gout or soft tissue crystals are there in this particular area. And we know by now that the first metatarsophalangeal is a typical location for gout. Now I want all of you to imagine with me. अभी लिखते नहीं, एक बार imagine करेंगे, because if you imagine, you can win. So the true level of intelligence can be judged by imagination, not by memory. ये बहुत ही इंपॉर्टेंट बात है. बच्चे रट रहे हैं, वो सोच रहे हैं रट रट के इंटेलिजेंट हो जाएंगे. ऐसा नहीं है. Intelligence will be by imagination, not by memorizing. It is not in your hippocampus, it is in your imagination. Okay, please see. ये यहाँ पे ना, everybody see with me बेटा. एक बार मेरे साथ देखने की कोशिश करो. एक बार देखो बेटा, भागो नहीं बेटा. हाँ, see, these are uric acid crystals. Now these crystals are going to rub along the bone. है ना, जो crystals है, ये bone है, so it will cause some pressure erosion onto the bone. So you can see here on the bone, you can see there is a erosion happening, which looks punched out, or we can say a rat bite erosion. But if you see, because it is not inflammatory involving the margin of the joint, it is the margin, the articular margin is preserved. So sparing the articular margin. Okay, can you see? आर्टिकुलर मार्जिन से दूर है, ये जॉइंट तो बचा हुआ, उसके थोड़ा आगे इरोजन है, बिकॉज दिस इज प्रेशर इरोजन हैपनिंग हियर. दिस इज व्हाट वाज डिस्क्राइब्ड बाय डॉक्टर मार्टेल. इट इज कॉल्ड एज द मार्टेल साइन. Okay, so this is what you see in a patient with gout. Can you can you further see uric acid crystals or any other investigation? We can do a dual energy CT, also called as the spectral CT. So if you remember, in my first class I described to you that gout uric acid crystals can be seen on a dual energy CT or spectral CT. Now I can see Nidhi is asking, I think a question पूछ रही है कि सर क्या ये सूडो गाउट नहीं हो सकता? नहीं हो सकता. सूडो गाउट में what you see is, what is pseudo gout beta? Pseudo gout is calcium pyrophosphate deposit. Pseudo gout is CPPD, calcium pyrophosphate deposit. So you will see cartilage will get calcified, so I can write it as, cartilage can be written as chondrocalcinosis. So when you will look at the x-ray of the knee in patients of you, so x-ray of the knee joint, you will see the cartilage, the meniscus will look calcified. So pseudo gout will have chondrocalcinosis. It is not uric acid, it is calcium pyrophosphate deposit. You will see it in the knee. You will see the cartilage in the knee getting calcified. Are you able to understand this? Are you able to understand this? Okay. So we saw gout, pseudo gout. Everybody understands the difference? Okay. Now let's go further. So once you have the concept in mind, you have the basic idea, let us look at some miscellaneous conditions. Can you name one miscellaneous condition that you've already studied in orthopedics or you will be studying? I'll just touch upon it. Name a condition which begins with osteoclastic destruction, begins with osteoclastic activity, followed by a chaotic, mad osteoblastic activity. ऐसी कोई बीमारी बताओ जिसमें शुरू में ओस्टियोक्लास्ट बोन को डैमेज करेंगे, फिर ओस्टियोब्लास्ट पागल हो जाते हैं और वो बोन बनाना शुरू कर देते हैं रैंडमली. Name a disease which begins with osteoclastic activity followed by mad chaotic osteoblastic activity. We all know that is Paget's disease of the bone. That is Paget's disease of the bone. So what will be the X-ray findings of Paget's disease? I'll quickly touch upon some of them. Suppose this is your skull X-ray. Suppose this is your skull X-ray. Paget's disease will begin with a large lytic lesion in the skull. शुरू में there will be a large lytic lesion in the skull. Why lytic lesion? Because it begins with osteoclastic activity. That is called as osteoporosis circumscripta. That is called as osteoporosis circumscripta. Large lytic lesion in the skull in patients with Paget's disease is called as osteoporosis circumscripta. Then what will happen? Then the osteoblast will become mad. So osteoblast will produce the bone randomly. I want all of you to focus on the screen. On the skull you will see multiple osteoblastic white spots because of bone formation. Can you see them? These are called as cotton wool skull. Cotton wool skull. Cotton wool skull. Clear? Second thing that will happen is, because of the osteoblastic activity, that means the bone is forming, the skull will become elongated. Skull will become elongated. So in Paget's disease, your skull becomes elongated like this cap. It becomes more long because bone is being formed. This cap is called as Tam-O'Shanter. So we use the word Tam-O'Shanter skull. A skull shaped like a Scottish cap called as Tam-O'Shanter. It is elongated. The reason is osteoblastic activity. Bone is being produced, so the skull is getting elongated. And not only the skull, your vertebra also becomes large. So vertebra becomes enlarged, and because of remodeling, you are able to see all four borders of the vertebra becomes dense and the vertebra becomes large. This is called as picture frame vertebra. So what do we see in Paget's disease? It begins with osteoporosis circumscripta, cotton wool skull, vertebra will be like a picture frame, skull will become elongated like a tam o'shanter. And if you see the long bones, in your skull, in the long bones, you will have a destruction which will advance towards the diaphysis. So that means you will have destruction which is starting at the end of the bone, advancing towards the center like this. So it becomes more like a flame or like a blade of grass lesion on the long bones. Okay, I'm repeating beta. I'm showing you the entire page. So we are looking at some miscellaneous conditions to cover up the orthopedic imaging before we go on to others. So these are named signs that they like to ask in the exam. Osteoporosis circumscripta, cotton wool skull, picture frame vertebra, tam o'shanter skull, a flame or blade of grass like appearance of the long bones is seen in Paget's disease. Now let me ask you a question, beta. Let me ask you a question. Now anybody tell me, is this picture frame vertebra? Is this picture frame vertebra? No. Why not? Because all four borders are not dense. Only the superior and inferior border is dense. So this is called as Rugger Jersey spine. This is called as Rugger Jersey spine. In which condition do we see Rugger Jersey spine? It is seen in patients with CRF, renal osteodystrophy. Seen in patients with CRF, renal osteodystrophy due to secondary hyperparathyroidism. So remember, primary hyperparathyroidism is because of a parathyroid tumor, parathyroid adenoma producing parathormone, while secondary hyperparathyroidism is due to CRF. So in CRF patients, you will have Rugger Jersey spine. But don't forget, there is one more cause of Rugger Jersey spine that you get wrong in your exam, that is osteopetrosis. What is osteopetrosis? Marble bone disease, a problem with the osteoclast function. Remember, a problem with the osteoclast function which leads to dense white marble-like bones, osteopetrosis, is another cause of Rugger Jersey spine. But always remember, the classic appearance of osteopetrosis is this. In osteopetrosis, because the old bone is not getting destroyed, in osteopetrosis, because the osteoclast is not functioning, so the old bone is not destroyed. So what happens is, there is a new bone formed within the old bone, that is called as the, I'm sure some of you know it, bone within bone appearance. So which condition shows bone within bone appearance? Osteopetrosis. You can see within the vertebra, another vertebra is visible. Bone within bone appearance, osteopetrosis. Okay, everybody follows? So I've given you three words, just three lines are there. Rugger Jersey spine, renal osteodystrophy. Picture frame vertebra, Paget's disease. Bone within bone appearance, osteopetrosis. Okay. Okay. Now, final images. Final image, and then we go to ultrasound. Final image. This is an X-ray of a infant or a newborn. What are you able to see in this infant? Anybody? Fracture, 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 fracture. Multiple fractures are seen. Multiple fractures are seen. Where are the fractures? This infant has multiple diaphyseal fractures. Multiple diaphyseal fractures. Okay. Now my question to you is, if you see these multiple diaphyseal fractures, what is this? This is callus. There is callus formation, but it is not there in this. So the fractures are in different stages of healing. That means some are happening at, they are all happening at different times. What will you suspect? We will suspect osteogenesis imperfecta. We will suspect osteogenesis imperfecta. Diaphyseal fractures in different stages of healing is the X-ray sign of osteogenesis imperfecta. But some of you might say, sir, why this is not child abuse? What is child abuse? Battered baby. How will you differentiate it from battered baby? उसमें भी तो multiple fracture होंगे. Why this is not battered baby? Anybody? So osteogenesis imperfecta would have that blue sclera also, but how will you differentiate on X-ray? Battered baby कैसे पता चलेगा? Battered baby will have, tell me, metaphyseal fractures. Okay, metaphyseal fractures, while here the fractures are diaphyseal. In battered baby, the fractures typically involve the corner of the metaphysis. So we'll call it metaphyseal corner fracture, or they will involve the entire metaphysis like a bucket handle. अभी धीरे धीरे बताऊंगा, घबराना नहीं, ठीक है. देखो, battered baby में the fractures are located in the metaphysis, typically at the corner of the metaphysis or at the edge of the metaphysis like a bucket handle. So corner fracture, bucket handle fracture, think of battered baby. If they say diaphyseal fractures in the shaft, it is osteogenesis imperfecta. Okay, clear? Okay, now my question is, let's see if you can answer. Okay, the question here is why it is happening, because in battered baby you are holding the baby by the thorax and you are shaking him. So when you shake the baby, his head is moving and his limbs are like this. So when you take your limb and do it like this, it breaks in the corner. The mechanism of injury is that violent swinging of arms and legs that happen when you are holding him by thorax. That leads to metaphyseal, but here you don't need to go into the mechanism, you just need to remember the location. यहाँ पे हड्डी कमजोर है तो बीच से टूटेगी, यहाँ वो violent swinging के कारण टूट रही है तो metaphyseal है. Battered baby is metaphyseal, battered baby is child abuse, while osteogenesis imperfecta is a weak bone. Other things that happen in osteogenesis imperfecta are, anybody? Wormian bone. And I mentioned Wormian bones earlier also. Anybody can remember and tell me? Anybody can remember and tell me? Where did I tell you Wormian bone before? I told you Wormian bones in hypothyroidism. What are these? So these are intrasutural bone. It is normal to have one or two intrasutural bone. If you have too many bones in the suture, it is called as Wormian bones. Okay. So Wormian bones are seen in hypothyroidism, osteogenesis imperfecta, rickets, Down syndrome. Wormian bones are seen in hypothyroidism, osteogenesis imperfecta, rickets and Down syndrome. My question to you is this, beta. Let's see how many of you can answer. What will you see in an X-ray of a patient with Down syndrome? Down syndrome में क्या क्या मिलेगा? आपने बोला वर्मियन बोन मिलेंगी, और क्या मिलेगा? What else do we see in X-ray of a patient with Down syndrome? Absent nasal bone. This you will read in your OBS also. Nasal bone is hypoplastic or absent in Down syndrome. Ribs, 11 pair of ribs. 11 pair of limbs. Anything else? AAD. What is AAD? Atlantoaxial dislocation. In Down syndrome, you develop atlantoaxial dislocation. That is why in all children with Down syndrome, you should do a screening X-ray of the cervical spine. Have you ever seen this question? कि किसी को डाउन सिंड्रोम है तो 3 साल की उम्र में उसका नेक का एक्सरे करना चाहिए to look for atlantoaxial dislocation. Again, if a Down syndrome patient is undergoing a surgery, it is important to do a X-ray of the cervical spine to rule out atlantoaxial dislocation. Okay, atlantoaxial dislocation is very important in Downs. Okay, and it will lead to clinodactyly. Clinodactyly means that the little finger is curved towards the ring finger. देखो मेरी तरफ, हमारी छोटी वाली फिंगर जो होगी रिंग फिंगर की तरफ कर्व्ड होगी. It is called as clinodactyly. I'm again repeating. Down syndrome X-ray can have Vermian bones, 11 pair of ribs, absence of nasal bone, atlantoaxial dislocation, and clinodactyly. C1, C2 involvement, that is atlas and axis, is not only seen in Downs, it is also a feature of rheumatoid arthritis. Always remember, most children believe that RA involves the hand and foot, but it also can involve atlantoaxial joint, and it can become life-threatening if the C1, C2 joint dislocates. So you should know this. So even in rheumatoid arthritis, you can have C1, C2 involvement. Now, if they say short fourth metacarpal, then mark the answer as Turner syndrome. But if they say metacarpal index is increased, okay, then don't get confused. Metacarpal index is the ratio of length to breadth of the metacarpals. So if the metacarpal index is increased, that means the metacarpals are thin and long. That happens in Marfan syndrome. What is that called as? That is called as arachnodactyly. So these are small things that many people get confused. Sometimes they will trick you by this. They will say, एक Down syndrome का patient है, उसका operation होना है, कौन सा जांच कराओगे? So any patient with Down syndrome who is undergoing any surgery, you should do a cervical spine X-ray to rule out atlantoaxial dislocation, because it might become risky during the surgery. If you don't know this and you flex the neck, you might extend the neck, or you might cause spinal cord compression. And every child of Down syndrome at the age of 3 years should undergo a screening X-ray to look for atlantoaxial dislocation. Increased metacarpal index, Marfan syndrome. Short fourth metacarpal, Turner syndrome. Clinodactyly, Down syndrome. Okay. I think Jetva Rohit has asked a question which I have missed. So he's putting question marks. So beta, you can just put the question again. Everybody gets it? Okay. Okay, everybody clear? Now let's go further. So what we have done is we have covered, some miscellaneous things in the bone, and I've tried to touch upon all the usual culprits for the exam. So now let's go on to ultrasound. Now ultrasound, okay, what is metacarpal index? Metacarpal index is ratio of length to breadth of the metacarpals. So if the metacarpals are thin and long, metacarpal index will be increased. And Shreya Jindal, arachnodactyly will also be seen in homocystinuria, which is correct. Homocystinuria में भी ऐसा होगा. बहुत अच्छा point है आपने बताया. Clear? AAD is atlantoaxial dislocation. And callus is that, that calcification that we saw, or the bone formation that we saw around the fracture. Arachnodactyly means spider-like fingers which are thin and long. Okay. And no, Martel sign का मतलब है erosion that we saw in the first metatarsophalangeal joint with overhanging articular margin. वो अलग है. Okay. Arachnodactyly is thin and long fingers that you see in patients with Marfan's and homocystinuria. Gaurav Chauhan. Okay. Now let's go further. What is ultrasound? Now we will gradually go to the surgical aspect of radiology. And today we will look at ultrasound and IVP. These are my goals for today. And I already know many of you have already promised me that today you will be happy to sit for longer duration. So what is the principle of okay, एक बच्चे ने पूछा है what is the C1 C2 okay, I think Jenny Newton I am saying C1 होता है first cervical vertebra और C2 होता है second. इनमें भी inflammation. In these bones also you can have inflammatory changes in rheumatoid arthritis. That is what I said. Okay. Now flame sign, and I think Mudita is again asking this. Flame sign and blade of grass sign are long bone signs of Paget's disease. Okay. Okay, I'll show you the callus on the X-ray so that it is clear, and then we will go forward. Okay, some bachas are getting a little restless. I will just show it to you. Now please see beta. Can you see there is some ossification around the fracture in this particular fracture, and in this fracture you cannot see. That means these are two fractures which are at different stages. That means they have happened separately. That means the bone is inherently weak. So if you see diaphyseal fractures in different stages of healing with deformities, like you see some deformity here, you will think of osteogenesis imperfecta. Okay. Now quickly answer a question. Let me ask you a question now. We are coming back to the ultrasound. Anybody, what is the principle behind ultrasound imaging? What is the principle behind ultrasound imaging? Ultrasound images are based on a principle called as piezoelectric effect. What is the principle of ultrasound image? Piezoelectric effect. Okay. What is piezoelectric effect? Let's try to understand. Suppose this is an ultrasound machine. This is the machine which has a crystal inside. Now this crystal is usually made up of PZT, lead, zirconium, titanium, titanate. So ultrasound machines are based on a principle called as piezoelectric effect, and they are using a crystal called as PZT. Okay. Now this PZT has a principle that whenever we apply electrical current to it, the crystal changes shape. So if you apply alternating current, the crystal starts to vibrate. If it vibrates, it produces sound. Now this sound will go into your body, strike different organs, come back, and that is how we produce the image. Okay. So ultrasound is based on sound. So we need to understand the property of sound here to understand what we will see in the images. First question. If the crystal has a thickness of T, the sound that will be produced will have a wavelength. What is the symbol of wavelength? Lambda of 2 into T. So any ultrasound machine will have a crystal inside it. If the crystal has thickness T, wavelength of sound produced will be 2 into T. And now tell me, what will be the velocity of sound? What will be the velocity of sound in human body? Anybody? What will be the velocity of sound in human body? Anybody? Now again repeating also, don't worry. All I said was that sound will have wavelength, velocity, frequency. We need to understand those things, otherwise we cannot understand the wave. So velocity of sound in human body is, now some of you are saying 300, 340, that is not correct. That is in air. When in our human tissues, it will be different. Velocity of sound depends on the medium. It is 1540 meter per second in the human soft tissues. Clear? So the name of the crystal was PZT, lead, zirconium, titanium, and the wavelength of the sound produced by ultrasound machine is dependent on the thickness. Velocity depends on the medium, which is human body, so it is 1540 meter per second. Clear? Now, so but the key question is, what about the frequency? What will be the frequency of this ultrasound machine? Frequency is C divided by lambda. C is the velocity, lambda is the wavelength. What is C? 1540 for human body. What is lambda? 2 by T. Okay. So this is the physics that we use in ultrasound machines. That is what the machine manufacturers use. I will give you a statement. You need to tell me true or false. Frequency of sound in ultrasound is inversely proportional to thickness of the machine crystal. Okay, anybody, true or false? Frequency of ultrasound is inversely proportional to thickness of the crystal. True. You understand? That is why I explained the entire dynamics to you. Now whenever we are applying electric current to a crystal, this crystal is going to vibrate and produce sound. And that sound will have wavelength and it will have velocity, which we need to know, otherwise how will we make the machine. Second statement we need to know is frequency of sound used in ultrasound is directly proportional to image resolution. Frequency of sound used in ultrasound is directly proportional to image resolution. True or false? It is true. Because higher the frequency, better is the resolution. Resolution means ability to see small diseases. Okay, I'm again repeating beta. Ultrasound में सबसे important concern is frequency, and frequency is directly proportional to image resolution. More the frequency, better is the image resolution. That means we should be using highest possible frequency. But there is a limiting factor. Frequency of sound in ultrasound is inversely proportional to depth penetration. ये बहुत जरूरी है, ये दिस इज क्रिटिकल बेटा, है ना. ये एक बार समझ गए ना तो बात बन जाएगी. देखो मेरे सामने टेबल पे देखो, जितना ज्यादा फ्रीक्वेंसी उतना ज्यादा रेजोल्यूशन, लेकिन उतना कम पेनिट्रेशन. Frequency of ultrasound is directly proportional to image resolution, but inversely proportional to depth penetration. I am going to give you an MCQ beta. I am going to give you an MCQ. Let's see if you can answer. Pancreas is better evaluated by ultrasound or CT? बताना बेटा. Which investigation is ideally suited for pancreas, ultrasound ki CT? Anybody can answer? Now see, if I'm doing ultrasound, abdomen ultrasound, where is pancreas? Pancreas is deep. To see deep structure, I need to reduce the frequency. Then only I will get the penetration. But if I reduce the frequency, I will lose the resolution. That means ultrasound is not good for pancreas and deep structures. CT is better. Are you clear? Are you able to understand this? So that is how we can apply logic to MCQ. So they have asked this question many times. Which investigation is ideally suited for pancreas, ultrasound, CT? It is CT scan. Are you clear? Are you able to understand? Because it's a deep structure. Ultrasound is not ideally suited. Clear? I will explain further with it, but let me just zoom out. So this is what we have done so far. Principal, piezoelectric effect, crystal, PZT. P is PB. Some people are getting confused. PB lead का बेटा नाम होता था, भूल गए हम स्कूल में. PB lead, zirconium, titanium. Thickness of the crystal is related to wavelength. 2 into thickness is equal to wavelength. Velocity in human body 1540. Frequency C by lambda. Frequency is inversely proportional to thickness of the crystal, directly proportional to image resolution, inversely proportional to depth penetration. एक बच्चा कह रहा है सर अल्ट्रासाउंड बैक से करें तो पीछे ना हड्डी आएगी, बीच में देखने नहीं देगी बेटा सूर्य, है ना. ट्राई इट, यू कैन सी व्हेन यू सी इट लेटर ऑन. फॉर रेट्रोपेरिटोनियल मनीष रेड्डी, अगेन CT वुड बी द बेटर थिंग टू डू फॉर रेट्रोपेरिटोनियल. Okay, now let's go further and see a table and let's try to understand the table beta. What is the frequency of sound used in routine ultrasound of the abdomen or routine obstetric ultrasound? Anybody? What is the frequency of sound used in routine abdominal ultrasound, routine obstetric ultrasound? Anybody? It is 3.5 to 5.5 megahertz. Routine ultrasound, which we do for abdomen and in pregnancy, we use a frequency of 3.5 to 5.5 megahertz. Now, if I compare it to, listen to me, if I compare it to a transvaginal ultrasound or a transrectal ultrasound, if I am doing a transvaginal ultrasound, the frequency can be higher because you are already closer to the target organ. So we use 5.5 to 7.5 megahertz. If you are doing a superficial organ ultrasound like orbit, thyroid, breast, scrotum. You don't need penetration, you need resolution. We use 8 to 12 megahertz. For endoscopic ultrasound, where we are directly in the organ, we use even higher frequency, 12 to 20 megahertz. Okay. Now, anybody now can look at this table and tell me, do you realize we want to use highest possible frequency, but we need to, if I want to increase the frequency, I need to take the organ, the probe closer to the organ. देखो, thyroid का ultrasound कर रहा हूँ. So I am just touching the organ. I don't need penetration. My frequency is much higher. Resolution is much higher. In abdomen, I need to reach the depth. So frequency is lower. You can see, if I have to look at the pregnancy through the abdomen or through the transvaginal route, you will see better resolution in TVS because the frequency is higher. Are you clear? Now, my question to you is this. Let's see if we can answer. Earliest evidence of fetal life will be seen on transabdominal ultrasound, transvaginal ultrasound. Anybody? Pregnancy पहले कब पता चलेगी, किस में पहले पता चलेगी, ट्रांसएब्डोमिनल, ट्रांसवेजाइनल अल्ट्रासाउंड? एनीबडी? It will be transvaginal ultrasound. Why? Because we are closer to the organ. If you're closer to the organ, you can use higher frequency, you can see better. Okay. Now, Bacha Aman Chaudhary is again and again asking, so what are the advantages and disadvantages of ultrasound? Ultrasound has the advantage that it can be done bedside, it is portable, there is no radiation exposure at all, it is based on sound, it is totally safe. It is totally safe in pregnancy. It has only one drawback. Only one drawback of ultrasound is it has a long learning curve. So that means the quality of ultrasound depends on the operator. Only drawback of ultrasound is that the machine is dependent on the person who is using it. So you must have heard in your practice as a student or as a person in your colony that इस आदमी का ultrasound बहुत अच्छा है. You understand? That is a skill. It is a skill dependent on the operator. This is the drawback of ultrasound. Okay. One bacha is saying, what is TRUS? TRUS is transrectal ultrasound. Okay. Transvaginal sonography, transrectal ultrasound. Are you clear, beta? TVS is transvaginal sonography. So what are the advantages of ultrasound? It is portable, cheap, no radiation, safe, low cost. Okay. But disadvantage, long learning curve. Okay. Piyush is saying, sir, thyroid और breast में higher frequency क्यों? Because you don't need penetration ना. बच्चे समझ. पीयूष मैं हिंदी में इंग्लिश में दोनों बता. अब अगर हम अल्ट्रासाउंड कर रहे हैं सुपरफिशियल पार्ट का, तो I don't need penetration. So higher frequency, better resolution. You need to reduce the frequency to get penetration, but these are superficial organs. So superficial organs, we have better frequency. We can use higher frequency. Okay, everybody clear? Now let's go further and answer this very, very important question. Now the question number one that we need to answer is, ultrasound is the investigation of choice. Ultrasound is the investigation of choice to differentiate a solid lump from a cystic lump. Ultrasound is an investigation of choice to do a solid versus cystic differentiation. What do we mean by this? Now see, if ever you have a lump, the surgeon is thinking, is this a tumor? Is it a benign thing? So cysts are usually benign, cancers are solid. We can differentiate this on an ultrasound. What will happen in ultrasound is, if you have a cyst, so anything that is full of clear fluid, will allow the sound to transmit, will allow the sound to freely transmit. So there will be no reflection of sound. So cysts on ultrasound appear anechoic. I am repeating, beta. Listen to me, I will explain everything. Okay, just wait and watch. Okay. Cystic lesions or anything which is filled up with water on ultrasound will allow the sound to freely transmit. They will appear anechoic. They will appear anechoic. Anechoic matlab there will no echo. Okay. Now, second is that the sound from the cyst is freely transmitting. So behind the cyst, a lot of reflection will happen. There will be increased through transmission of sound through the cyst. Cyst क्योंकि साउंड को रिफ्लेक्ट नहीं करेगी, उसमें से ज्यादा साउंड पीछे जाएगी. Now let me explain it to you with a image. इमेज से देखते हैं, ठीक है. आई थिंक कुछ बच्चे नहीं समझ पा रहे, मैं उसको I'll show it with the image. Now I want you to see this image. Now can you see a dark structure here? This is anechoic, absolutely black. There is no reflection happening through the cyst, it is anechoic. But because the cyst is freely allowing the sound to transmit as compared to other tissues, it is allowing the sound to transmit. Distal to the cyst you will see increased brightness. This is called as acoustic enhancement. Acoustic enhancement. Okay, I am again repeating beta. I am again repeating. Try to remember these two lines. दो लाइन याद कर लो. Solid versus cystic is best differentiated by ultrasound. Cystic lesions on ultrasound appear anechoic and they will show distal acoustic enhancement. Shadow नहीं है बेटा, याद कर लो. Enhancement. The area distal to the cyst will be more bright because of increased transmission of sound that happens in the cyst, because water does not reflect sound. Okay. Now Trisha, Ghosh, try to understand. जैसे हमने in the CT scan we use the term dense, hypodense, hyperdense. MRI we use intense, and ultrasound we use the term echoic, because everything is based on how much sound is being reflected. Okay. Now clear? Now that means investigation of choice to differentiate a solid lump from a cystic lump is ultrasound. Cyst will be anechoic with distal acoustic enhancement. If the cyst has septae, solid tissue, solid component, mural nodule, internal vascularity, then what will you suspect? I said, so far I have said that the cysts are benign. Solid lesion will be tumor, but if a cyst has septa, solid component, mural nodule, internal vascularity, it could be a cancer, it could be a malignancy. That is how sound helps. Now समझना है, if the sound strikes a organ and reflects, that area will look more white. If it is not reflecting, it will appear black. Are you clear? Are you able to understand? Okay. Now once you are able to see the concept, I will take you further. Now see the second image that I wanted you to see in ultrasound. Very, very important image. I am sure some of you will be able to diagnose also. I want you to understand only 10% of the gallstones are radio opaque. Okay, read this line with me. Read this line with me, beta. एक बार ये line पढ़ के देखो. Only 10% of the gallstones are radio opaque. सिर्फ 10% gallstone ही X-ray पे दिखाई देते हैं. Okay, the others are not visible on X-ray. Okay, so tell me now, on the basis of this, investigation of choice for gallstones will be. Investigation of choice for gallstones will be ultrasound, because X-ray cannot show them. Only 10% can be seen on X-ray. We need to do an ultrasound. Are you able to understand my concept? Okay. Did you realize that water does not reflect sound? That is why it was anechoic. Okay. Now quickly answer this question now. Let's see how a gallstone will look like. I want you to see this dark area is the gallbladder. This is the gallbladder. Now please see, the sound comes into the gallbladder and it strikes the stones. It is striking the stone. Now stone is hard. Because the stone is hard, the sound gets reflected back. Now because the sound is totally getting reflected back, the stones are appearing very, very white. Very, very white. So gallstones are appearing hyperechoic. They are appearing hyperechoic. And because the sound is getting reflected back, distal to the stones, you will see a dark area which is called as acoustic. Anybody can let me know in the chat? Acoustic shadow. Investigation of choice for gallstones, ultrasound. Ultrasound or ultrasound, gallstones on ultrasound appear hyperechoic with acoustic shadowing. Hyperechoic with acoustic shadowing. Now, let us do some related MCQs. Okay, let's do some related MCQs. Okay, anybody? Investigation of choice for gallstones, ultrasound. Investigation of choice for CBD stones. If they change the question, the stone is not in the gallbladder, it is in the common bile duct, then your answer should be MRCP. Investigation of choice for CBD stone is MRCP. Investigation of choice for urinary stone, which I will tell you a little later again, is NCCT abdomen. Investigation of choice for stone in the salivary gland, NCCT abdomen. NCCT of the salivary gland. So sometimes you might miss out on these. These are questions based on stones. Gallstone, ultrasound. CBD stone, MRCP. Urinary stone, NCCT. Salivary gland stone, NCCT. And another fact that I wanted you to know here is, if they say investigation of choice for acute cholecystitis, acute inflammation of the gallbladder, what is your answer? Even for acute cholecystitis, ultrasound is considered the investigation of choice. Even for acute cholecystitis, ultrasound is considered the investigation of choice. How it will look like? Please see. The gallbladder in inflammation will be distended. It will have edematous walls, pericholecystic fluid, because the capillaries will be leaking, there will be pericholecystic fluid. What else? What else will happen in inflammation? Inflammation will lead to pain. So if you press the gallbladder with your ultrasound probe, you will see tenderness. This is called as sonography Murphy's positive. So again, I am repeating two MCQs for you. Quickly answer. Investigation of choice for acute cholecystitis, ultrasound. What are the ultrasound features of acute cholecystitis? Distended gallbladder, edematous wall, pericholecystic fluid, sonographic Murphy's sign positive. What is Murphy's sign? Tenderness. Okay. Everybody understands these related questions? Okay. Now, related to this, there is an older concept but sometimes asked. Before advent of high quality ultrasound machines, there was a test which was used for acute cholecystitis called as HIDA scan. What is HIDA scan? Anybody? Hepatobiliary immunodiacetic acid. HIDA scan is hepatobiliary immunodiacetic acid. Okay, let's try to understand. This HIDA is taken up by the hepato, that means taken up by the liver. It is taken up by the liver, and from the liver it is excreted into the bile. From the liver it is excreted into the bile. From the bile it goes into the storage, which is gallbladder, then it goes into the bowel. Now imagine now Everybody listen to me. Pericholecystic fluid, Gomati, means fluid around the gallbladder, because the inflammation will lead to capillaries leaking, so there will be some fluid collection around the gallbladder. Okay. HIDA is the isotope scan which is taken up by the liver, excreted into the bile. If you have acute cholecystitis, what will happen? Listen to me. If you have acute cholecystitis, your gallbladder wall will be inflamed, edematous. If the gallbladder wall is edematous, what will happen? Cystic duct will become blocked. So if your gallbladder is edematous, cystic duct becomes blocked. So when you give HIDA, it is taken up by the liver, goes into the bile, goes into the bowel, but cannot go into the gallbladder. I am repeating, non-visualization of gallbladder is non-visualization of gallbladder in HIDA scan is a sign of acute cholecystitis. But now we don't believe that this is the investigation of choice, because ultrasound has become very good now. Investigation of choice, ultrasound. Everybody understands? Clear? Okay. Now quickly answer now, beta. Quickly answer, very, very important. Edema will be seen on ultrasound as thickened walls of the gallbladder. Wall of the gallbladder will be thickened. So these are some miscellaneous questions on the topic that we have touched upon, the gallbladder. So what I want you to see the table again. Investigation of choice for acute cholecystitis is ultrasound. On HIDA scan there will be non-visualization of gallbladder. This is happening because this gallbladder wall, if it is thickened, if it is edematous, it causes obstruction of the cystic duct. Okay. Now let's go further and try to understand what happens in chronic cholecystitis. We've seen acute, but what happens in chronic cholecystitis? Chronic cholecystitis will lead to fibrosis. So chronic inflammation always leads to fibrosis. So if there is fibrosis, what will happen? Gallbladder will become contracted. In acute cholecystitis, gallbladder was distended. Chronic, it will become fibrosed. Okay. In fibrosis, the gallbladder will become contracted. And suppose you have gallstones, what will happen? If I do ultrasound of this patient, on ultrasound, I will only see the wall of the gallbladder, echoes because of the stone, and shadow behind it. I will again repeat. Everybody listen to me. Everybody listen to me. And in chronic cholecystitis, the gallbladder because of fibrosis becomes contracted. So all you see on ultrasound is the wall of the gallbladder, echoes, shadow. I will show it to you how it looks like. I want you to see this image, beta. All of you see the image with me. This is the gallbladder wall. All I can appreciate is the wall. I cannot see the lumen because it is contracted. Then I see another white area which is because of the stones. So there are echoes because of the stone, followed by shadow. This is called as the West sign. Anybody, can you tell me what is West sign? Can you tell me what is West sign? Can you tell me what is West sign? Wall, echo, shadow sign. Seen in cholelithiasis, that means gallstones with chronic cholecystitis. Okay. If a patient with gallstones develop chronic inflammation, you will see West sign. West means you will not see the gallbladder. All you will see is the wall, echo, and shadow. Wall, echo, shadow sign is a sign of chronic cholecystitis with cholelithiasis. Okay. Now, but what can we get confused in the exam with? I want you to see another gallbladder image which is an important one-liner in your exams. I want you to see another gallbladder image, and I want you to see this area in the gallbladder. Can you see in this patient from the gallbladder, there are some tail-like appearance coming out? Can you see there are some tail-like areas coming out from the gallbladder wall? This tail-like appearance is called as the comet tail sign. Comet tail appearance. Why do we have a comet tail appearance coming from the gallbladder wall? Now there is a condition which I'll try to explain to you. Let's see if you know it or not. If this is your gallbladder, in some people your gallbladder mucosa, gallbladder columnar mucosa outpouches into the muscularis layer. Outpouches into the muscularis layer. So muscularis adeno is going into the adenomyomatosis of the gallbladder. And this outpouching of the mucosa in pathology is called as Rokitansky-Ashkoff sinus. It is called as Rokitansky-Ashkoff sinus. Now, today we know when the sound strikes the Rokitansky sinus, part of it is reflected, part of it is transmitted, which is called as the comet tail appearance. So if you see comet tail appearance from the gallbladder, the diagnosis is adenomyomatosis. Adenomyomatosis. Kshitij is again and again saying, sir, stone or polyp mein kya farak hoga? Polyp will not have the acoustic shadow because it is not so dense as it is soft tissue. Stone is hard. So stone के पीछे acoustic shadow होगा, polyp के पीछे नहीं होगा. Okay, Kshitij. Now anybody? So adenomyomatosis because of the Rokitansky-Ashkoff sinus shows comet tail appearance on ultrasound. Now what can we get confused with? This is comet tail, Jitendra VP. This is your comet tail. Can you see from the wall of the gallbladder? You can see this white tail-like thing. These are comet tail appearances. Now what we can get confused with are two things. One is Rokitansky protuberance. Anybody? In which condition have you heard of Rokitansky protuberance? Rokitansky protuberance तो कुछ और है. Can you tell me in which condition did you hear about Rokitansky protuberance? Rokitansky protuberance is seen in dermoid, ovarian dermoid. So in dermoid you have that hair plug called as the Rokitansky protuberance, which has the acoustic shadow behind it leading to tip of the iceberg sign. So don't get confused. Rokitansky protuberance dermoid में मिलेगा, Rokitansky-Ashkoff sinus adenomyomatosis में मिलेगा, and the dermoid cyst has an ultrasound appearance called as tip of the iceberg sign. Second question beta, remember this, is this. Uterus में adenomyosis होगा. Uterus में if the endometrium goes into myometrium, we call it adenomyosis. So adenomyosis पे there are three questions on radiology. Anybody? Investigation of choice? MRI. Ultrasound will show. What is the ultrasound appearance of adenomyosis? Anybody? You will have white bands coming from the endometrium, from the outpouching of endometrium into the myometrium, which is called as Venetian blind appearance. Venetian blind appearance. Have you heard of this before? So suppose this is your uterus, endometrium. In adenomyosis you have some white black bands like this called as Venetian blind sign. So just don't get confused between the terms. Comet tail appearance of gallbladder, adenomyomatosis. Adenomyosis is a uterus condition. MRI investigation of choice. Ultrasound has Venetian blind. Rokitansky protuberance is seen in dermoid. Ultrasound has tip of iceberg sign. Tip of iceberg sign on ultrasound seen in dermoid cyst. Dermoid में क्या होता है? अगर ये dermoid है तो इसमें dermoid में जहां पे हेयर और वो प्लग होगा ना, जो dermoid का जो प्लग होता है उसके पीछे shadow होता है. This hair and calcium will have shadow behind it. So This entire area will be black and this will be white, so it looks like a tip of iceberg. You can forget about it, just remember the name. Tip of iceberg sign on ultrasound is the sign of Rokitansky protuberance on ovarian dermoid. Okay, dermoid of the ovary, yes, correct. Okay, so where else do we use ultrasound? Always remember, if they ask you initial investigation to be done in a patient with jaundice, initial radiological investigation to be done in a patient with jaundice is also ultrasound, because it helps you to differentiate a medical cause from a surgical cause. Initial investigation in jaundice, initial radiological investigation in jaundice, ultrasound. So if you have understood all this, okay, if you have understood all this, let me okay, what is Venetian blind? Venetian blind बेटा जो आपकी खिड़की पे आपने देखा होगा blinds होते हैं साक्षी, that is Venetian blind. So you see alternate white and black bands in adenomyosis, that is called as Venetian blind on ultrasound. Okay, now let's go further. Let me take you a little bit further into the ultrasound imaging and ask you, okay, let me just go further into a blood vessel. Suppose this is a blood vessel. Anybody look at the blood vessel and answer. In the blood vessel, these are your RBCs and different blood cells which are flowing. Okay, everybody quickly answer. After the ultrasound is done, we will take a break and then start IVP. Okay, everybody? Okay, let's start now. So if this is a blood vessel, because we need to look at the ultrasound. So in a patient with jaundice, the first radiological test you will do will be ultrasound, because in hepatitis the liver will be swollen. In surgical causes the biliary radicals will be dilated, so we can differentiate between the two. Okay, do you want to take a break and then continue? Okay, then I will continue beyond the stipulated time. Okay, that is okay. Okay, I see most of you are asking for a quick break or for dinner maybe. So let's take what do you suggest? Will 15 minutes be okay? Will 15 minutes will be okay with you? Okay, let's take a 15 minutes break, get your dinner here so that we can eat together. 15 minutes, let's be back, and then we will look at, there is a little bit left here on ultrasound, just 4 images, okay, and then we have to do the IVP part. Okay, so we have around 1 hour class left after this, so please be back in 15 minutes. We'll do another between 1 and 1.5 hours. I have to do IVP today. Okay, Hanji, so let us start again. So let's see now. So we have already talked about some ultrasound findings. Now I saw some people were getting confused between the ultrasound appearance of air and water. Water will be black. What about air? What will be the ultrasound appearance of air? Okay, before I show you the Doppler part, but let me ask you a question. What will be the ultrasound appearance of air? Now I want all of you to understand this small concept with me. Suppose this is your soft tissue in your body. Suppose this is your soft tissue in your body, and suppose this is a bowel loop. Okay, suppose this is your soft tissue and this is your bowel loop. Okay, in the bowel loop you have air. Now I want all of you to answer one small question for me, very, very small. Suppose this is a interface between two things, maybe two elements, and a wave enters this. Maybe it has different density, density 1, density 2. In school they must have taught you any time a wave enters, if the density changes, the wave will bend. What principle am I talking about? What principle am I trying to tell you? Refraction. So if there is a density change at an interface, the wave should bend, which is called as refraction. But if the density change is too much, if the density is changing too much at the interface, then what will happen? अगर इन दोनों जगह के बीच में डेंसिटी में बहुत ज्यादा फर्क है तब क्या होगा? एनीबडी? इफ द डेंसिटी चेंज इज टू मच, then the wave bends so much that it gets, tell me, internally reflected. It gets, it gets reflected back. Total internal reflection happens. Are you clear? Okay. Now tell me, beta. Similarly, when the air enters the soft tissue, when it goes to bowel which has air, the density change is too much. Density change in our body is too much. What will happen? The sound will get reflected back. So as a result, air-filled structures on ultrasound appear hyperechoic because they are reflecting the sound, and they show distal acoustic shadow, which is, we cannot believe it, but it is true. You understand? Air and water on ultrasound are different because air-filled structures, they show reflection of sound, they appear hyperechoic, they show distal acoustic shadow. Okay. Now, why is this important? And how this can be used clinically? I will explain to you. Just give me 1 second, I am explaining to you. Everybody listen to me. Suppose this is your body. Okay. This is the abdomen, pelvis. So suppose in the pelvis, I want to look at the pelvic structures. I want to see the uterus, ovary. I cannot see because there are bowel loops sitting there. Suppose you are doing an ultrasound from here. Suppose I am doing ultrasound from the pelvis. I cannot see pelvic viscera because the bowel loops are sitting there and they have gas and the sound is getting reflected. Okay. Bowel loops in the pelvis are not allowing me to see pelvic viscera. What should I do? मैं ऐसा क्या करूं कि देख पाऊं? Now imagine now, suppose I ask the patient to make the bladder full. When the patient will make the bladder full, what will happen? The bowel loops will be displaced outside the pelvis. Bowel loops will be pushed outside the pelvis. And through the bladder, because bladder has water, through the bladder sound can pass and you can see the pelvic structures. Are you able to understand this or not? That why for pelvic ultrasound, I'm sure you have seen this already in hospitals. Whenever we do pelvic ultrasound, we need a full bladder. Why? Because full bladder gives us a window to look at the pelvic viscera. Full bladder gives us a window through which we can see the pelvic viscera. Are you able to now understand that why outside the ultrasound room ladies are drinking water? Because if the bladder is not full, you cannot see the pelvic viscera, you cannot see the uterus, ovaries, because the bowel loops are obscuring everything. Why? Because air in the bowel loops reflects the sound back. Interesting concept? Yes? But at least you understand the why behind it. Why during pelvic ultrasound you need a full bladder? Because it is all simple, it is all interlinked, but when we understand, we feel joy. Okay? My question is second. I will give you one more similar concept. You will like the concept when I tell you. Okay? Concept is coming up. Beta, concept. Okay? Suppose this is a blood vessel. Suppose this is a blood vessel. In the blood vessel, these are your blood cells. And blood cells are flowing. Everybody listen to me, beta. Suppose I send sound into the body, it strikes the RBCs, it strikes the blood cells and it comes back. Okay? Everybody listen to me. Everybody listen to me. एक बार सुनो मेरे साथ बेटा, सुनने की कोशिश करो. Now the blood vessels have blood cells which are flowing. If I send the sound of frequency F into the body, when it strikes the RBCs, the frequency changes to Fx. I am saying, I want all of you to listen to me. Whenever sound strikes a moving object, frequency changes. Whenever sound strikes a moving object, the frequency changes. Okay. What principle did I just describe in front of you? This is the principle that was described by Doppler in Europe when Doppler was standing on a railway station. He saw that when the sound is produced by a moving train, frequency shifts. So moving objects demonstrate frequency shift is called as Doppler effect. Okay, it is called as Doppler effect. Now imagine now if somehow I can use this frequency shift to create an image. It will look something like this. Try to understand, I will explain to you. Now what we are doing here is, I am sending sound into the body, sound is getting reflected back. From the static soft tissues, from the soft tissue where there is no movement, there is no frequency change, so they are appearing black and white. But area which is having frequency shift, that means that is moving, we are showing with color. What is this investigation called as? This is called as color Doppler. So color Doppler can show us blood flow as colors. But the question arises, what color should we use? What color should we use to show blood flow in Doppler study? What color? So we decided to use red or blue depending on the direction of flow. So in Doppler study, in color Doppler, we decided to use the direction as the determinant of the color. Flow towards the ultrasound probe is shown as red. Flow away from the ultrasound transducer is shown as blue. Okay, let me explain. So if I keep the ultrasound here, if this flow is coming towards it, by convention we will show it as red, away blue. Okay, so this is what is called as color Doppler study. So in your exam they might ask you, in color Doppler red and blue color is determined by, in color Doppler red and blue color is determined by direction of flow. Red is flow towards the probe, blue is flow away from the probe. Okay, now let us understand why this all helps us. What is the role of Doppler? Let's try to see some role of Doppler. I want you to first see this particular image. This is your common carotid artery, internal carotid artery, external carotid artery. This image has been obtained if I keep the probe here at the carotid bifurcation. Okay. So what is this investigation? This is carotid Doppler. What is the role? It helps you to screen for carotid stenosis. And you can see this is a previous NEET PG question in front of you. A previous NEET PG question. Carotid Doppler, okay, anybody, carotid Doppler is used for screening for carotid stenosis. Screening matlab, if I want to see an asymptomatic person, if the carotid is narrow, maybe somebody is smoker, diabetic, I want to see his carotid, I can see with Doppler. Okay, clear? Okay, second role of Doppler is, it is used to screen a patient for renal artery stenosis. It can use for screening of renal artery stenosis. I am sure when you were studying in pediatrics, they told you that one of the curable causes of hypertension in children or young people will be renal artery narrowing, renal artery stenosis. So renal artery stenosis, you can do screening by Doppler. But if they say investigation of choice, go for catheter angiogram. Renal artery stenosis, screening is done with Doppler, investigation of choice, catheter angiogram. The advantage is that if you have renal artery stenosis and if you do a catheter angiogram, you can even do angioplasty and treat the hypertension. Okay. So now quickly tell me, two questions where Doppler is the answer. Carotid stenosis screening, renal artery Doppler screening. Okay, we will use renal artery stenosis Doppler screening, but investigation of choice for renal artery stenosis, catheter angiogram. Okay, quick question. Okay, let's see if you can answer, beta. I'm asking very important question. What is the investigation of choice for deep vein thrombosis? What is DVT? Deep vein thrombosis. DVT is a thrombus in the vein. If you keep the probe on the leg vein, if there is no flow, we can suspect DVT. Again, Doppler is the investigation of choice. Okay, but there is one DVT which is invented by DAMS. What is that DVT that we invented? That is DAMS visual treat. We have been doing DVT, I think, for now 10 years now. Every year, around 2-3 months before the NEET PG exam, we conduct a DVT event where we cover a lot of revision in 3 or 4 days, very, very fast, and we get around very high strike rate in the NEET PG in that revision. So that is DVT. Don't forget to attend this year's DVT. Last 2 years DVT sessions are already available to you on your eMedicos app, which can be reused for revision. They are very, very good. Okay, so DVT is deep vein thrombosis, investigation of choice, Doppler. And anybody can answer this tough question now, Central Institute question now. Can I do a Doppler through the skull? Yes, we can do a transcranial Doppler. Any indication? Any indication for doing a transcranial Doppler? It is used to look for vasospasm in a patient with subarachnoid hemorrhage. We can do a transcranial Doppler in ICU in patients with subarachnoid hemorrhage to look for vasospasm. In vasospasm, we can give calcium channel blockers, and that is how the role of transcranial Doppler is. Okay, I'm not saying transfrontal, I'm saying transcranial Doppler. Okay, now another place where we use Doppler very commonly, and it is very important MCQ, is anybody? Pregnancy in IUGR. In obs and gynae, I'm sure you must have studied or you might have heard of. In IUGR, we look at the umbilical artery Doppler. In IUGR, we look at umbilical artery Doppler. Okay, anybody tell me? Umbilical artery is reflecting the fetoplacental circulation. It should have forward flow in both systole and diastole. Okay. In pregnancy also you will read about Doppler. I'm just touching upon it here just to make sure that the image book is complete. In pregnancy we use Doppler in IUGR patients. Most important artery in IUGR, umbilical artery. Umbilical artery sees the fetoplacental circulation. It should have forward flow in both systole and diastole. I will show it to you, beta. I will show it to you, beta. देखो मेरे साथ. Now please see, this line is the baseline. This line is the baseline. If you see forward flow above the baseline in both systole and diastole in umbilical artery, it is the normal pattern. This is how the normal flow pattern will be. Okay. Now, in IUGR, the placental resistance will be high. So, if the placental resistance will be high, diastolic flow will start to get compromised. So, anybody look at this image number 2 and tell me what are you able to see? Image number 2, the diastolic flow is absent. Okay, diastolic flow is absent. And number 3, anybody now try to answer better. Number 3. Now fetal, everybody listen to me. Fetal heart has to pump blood through the umbilical artery into the placenta. Now placenta is having increased resistance. Fetal heart has to pump against resistance. So it has to work very, very hard. If you have to work very hard, the heart might fail. What might? Fetal heart might fail. If the fetal heart fails, what will happen? The forward thrust in the diastole will be totally lost and the flow will start to reverse. When the fetal heart failure happens, when the IUD is about to happen, you will see reversal of the end diastolic flow. So that means if you see reversal of diastolic flow in the umbilical artery, it is a ominous sign. It tells you impending IUD. IUD is about to happen, the heart is failing, you need to do cesarean to take out the baby. Are you able to understand this? That forward flow मतलब baseline के ऊपर दिखना चाहिए flow. यहाँ पे देखो मेरे साथ बच्चे, जो आई थिंक एक बच्चा साइन किरण बोमाना, प्लीज सी बेटा, कैन यू सी देयर इज अ फ्लो बिलो द बेसलाइन इन डायस्टोल, दैट मीन्स इट इज इन द नेगेटिव डायरेक्शन. दिस इज ओमनियस. If you see reversal of diastolic flow in the umbilical artery, it indicates impending IUD. You need to do the urgent cesarean to terminate the pregnancy, otherwise you might have IUD. Okay, I am repeating for Maria Thokam again. Beta, Maria, please listen to me. Beta, एक बार सुनने की कोशिश करो. Easy है, आपने ऑब्स में पढ़ा भी है ना? Listen to me. Normal umbilical artery should have forward flow in both systole and diastole. In severe, it might be absent diastolic flow. If you see reverse diastolic flow, that means the fetal heart is failing. That means it is an ominous sign. It is impending IUD. You should terminate the pregnancy. ओमनियस मतलब बहुत खराब साइन है. अनमोल त्यागी, ओमनियस मतलब बहुत खराब साइन है. रिवर्सल ऑफ डायस्टोलिक फ्लो इज अ ओमनियस साइन. Second place where we will use Doppler in pregnancy is anybody? Is PIH. Now you should always look at the uterine artery also. Uterine artery in the first 22 weeks has high resistance flow. After 22 weeks, low resistance flow. Uterine artery is supposed to have high resistance flow in the first 22 weeks. After that, you will have low resistance flow. This is how the high resistance flow will look like. Sharp peak, diastolic notch, okay, while broad peak and good flow throughout the diastole, no notch, is low resistance flow. What does this mean? This means, try to understand, then I'll explain. Try to explain, but I'll explain. If you see persistent diastolic notch, everybody write down, in the uterine artery, even after 22 weeks, what will you suspect? That means the uterine artery circulation is still high resistance. That means the placental sinusoids have not formed properly, the resistance is still high, and that is what is the pathogenesis of preeclampsia. So if you have persistent diastolic notch after 22 weeks, it can be considered as a predictor for preeclampsia. Everybody understands? Clear? Okay. So absence of diastolic flow, Rohan Sanjay Patil, you had asked a question. Absence of diastolic flow in the umbilical artery indicates severe IUGR. And most of the time you will not wait till the reversal to happen. आप इंतजार नहीं करेंगे कि हार्ट फेल हो जाएगा तभी सिजेरियन करोगे, हम यहीं पे सिजेरियन कर देंगे. क्लियर? एंड एक बच्चा बार बार पूछ रहा सर ये ब्लू का है. So in the internal carotid artery, physiologically there is a slight reversal that happens. This is a physiological phenomena that happens in the proximal internal carotid artery. Okay, clear? I'm again repeating the preeclampsia part. For preeclampsia, we use the uterine artery Doppler. In uterine artery, after 22 weeks, it should have low resistance pattern. You should not see the diacarotic notch that you see in the first 22 weeks. If the notch is persistent after 22 weeks, it is a predictor for preeclampsia. Okay, Manish and Lakshmi? Okay. Third artery that we see in pregnancy is fetal MCA, fetal middle cerebral artery. If it has increased peak systolic velocity, if you have increased peak systolic velocity, it is a indicator of fetal anemia. if in the fetal middle cerebral artery you have increased peak systolic velocity, it is anemia. Okay. Umbilical artery has two, is the placental vessel goes into the placenta, so it is supposed to have low resistance flow. It should have flow in the positive direction only in the normal patient. Okay, Sangram? Okay, clear beta? So this is the role of Doppler in pregnancy. Very quickly, anybody tell me, quickly look on your screen and tell me, is this a Doppler image? Is this a Doppler image? No, this is not a Doppler image. This is a single dimensional ultrasound image based on amplitude of sound called as A scan. Okay, this is called as A scan. Any one of you can answer beta. A scan is based on length. It is based on single dimension. It can measure the axial length of the globe. So this has role in the ophthalmology. A scan is used in to measure the axial length of the globe. So this is A scan. It is a single dimensional ultrasound based on amplitude. The routine ultrasound is B mode. B mode is two-dimensional ultrasound. Routine ultrasound is called as B mode because it is two-dimensional ultrasound. In ophtha we also use A scan to measure the length of the globe. Second question is, do we have 3D ultrasound also? Today, ultrasound machines also have the capability to create 3D ultrasound. 3D ultrasound. Okay. Okay, anybody, where will you use investigation of choice for? Mullerian abnormalities, 3D ultrasound. Congenital malformations like cleft lip, cleft palate in the antenatal ultrasound, 3D ultrasound. 3D ultrasound is used for Mullerian abnormalities to find if we are dealing with bicornuate uterus, septate uterus. Also used for congenital malformations to see cleft palate, cleft lip antenatally, or any spina bifida. Antenatal malformations can be seen on 3D ultrasound. Okay. And ek bacha was asking, sir, how do we know anemia on Doppler? I will explain to you, beta. It's a good question, but I'll explain to you. I thought you might be knowing, but let me explain. Anemia, you have hyperdynamic circulation. In anemia, you will have hyperdynamic circulation. So if the fetus has anemia, his brain vessels will have high velocity. So if you have increased peak systolic velocity in the fetal middle cerebral artery, it is a marker of fetal anemia. Okay? Everybody understands? Okay. Now anybody quickly, what is this ultrasound? This is also a single dimensional ultrasound depending on motion. So we call it M mode ultrasound. This is an ultrasound image which is only showing us movement. So we can use it during echocardiography to see the movement of the cardiac walls and walls. Whenever we want to see the movement, we use M mode. M mode is also used in extended fast. M mode is also used in extended fast to diagnose pneumothorax. Barcode sign. Do you remember barcode sign on M mode? Pneumothorax. And it is also used to measure fetal heart rate in pregnancy. Okay. Anybody? Should I repeat? M mode ultrasound is used for echocardiography, extended fast, and fetal heart rate. Today, ultrasound can also see the stiffness of the organ, which is called as ultrasound elastography. Ultrasound can also see the stiffness of the organ, which is called as ultrasound elastography, which is called as fibroscan in the liver. Anybody, can you tell me in which condition do you want to see stiffness of the liver in fibroscan? Anybody? That is cirrhosis. Early diagnosis of cirrhosis you might have heard of, that in chronic liver disease patient. Today you can measure the stiffness using ultrasound elastography, which is nothing but a ultrasound technology which assesses the stiffness of the organ. Everybody understands? Clear? So much so about ultrasound 3D, M mode, A mode, B mode. Now let's quickly move on to the final part of the class. It's a small topic and we will try our best to cover it. Please identify the investigation shown to you. Please identify the investigation shown to you. Anybody? Identify the investigation shown to you. This is IVP. What is IVP? Intravenous pyelography. What do we mean by intravenous pyelography? It means we have given intravenous dye. Which dye? Same as what we did in CT. Remember, iodinated contrast. We have given intravenous dye. The dye has gone into the kidney, into the pelvic calyceal system, into the ureters, and into the bladder. So you can see the ureters, the urinary bladder, the kidney, excretory system. Okay. Now, so we have given intravenous dye and looking at the urinary tract. But what is the important question here? Important question is, IVP is no longer the investigation of choice for urinary tract disease. Okay. Always remember, IVP is no longer the investigation of choice for urinary tract disease. So what do we do for urinary tract? Which investigation do we do for urinary tract nowadays? Now we prefer the king of urinary tract is CT scan. Okay. IVP is no longer the king of urinary tract disease. Now it is CT scan. I will explain to you. I will give you some quick MCQs here which are confusing but very, very important. Okay. Let's see an answer. Investigation of choice for urinary stone. Urinary tract stone is NCCT. It is not IVP. Okay. Earlier, in the olden times you would say IVP. Now we say NCCT. Okay. Second question, beta. Let's see if you can answer. The stone question. Stone. Uric acid stones on X-ray are visible or not visible? Uric acid stones on X-ray are invisible, not visible. So how do I write it technically? I will say radiolucent. Radiolucent. But interesting thing is CT scan has the capability to even show you uric acid stones. CT scan can even see uric acid stones, although on the limited ability of X-ray we miss it, but CT scan, because it has a gray scale which is far wider than what we see on X-ray, CT scan can even show us uric acid stones. And always remember, uric acid stones are managed medically, oxalate stones are managed surgically. So it is very important to identify. So X-ray invisible, CT visible. Okay. Third question, integrated question. HIV positive patient on treatment develops ureteric colic. X-ray normal, CT normal. HIV positive patient on treatment develop ureteric colic. X-ray is negative, CT is negative. Both of them are normal. But ureteroscopy shows a stone. What will you suspect? What type of stone is this? So the key word here is HIV positive patient on treatment. and if you treat a HIV positive patient with protease inhibitor indinavir, so indinavir stones are not visible on X-ray, not visible on CT, investigation of choice, ureteroscopy. Okay, so always remember that sometimes we miss out on these questions in the exam if we don't see the full picture. Indinavir stones, indinavir is a drug that is used in HIV patients. These stones are not visible on X-ray, not visible on CT. Clear, everybody? So can you see some stone MCQs? Okay, I will make it more tough for you. Now anybody, investigation of choice for renal trauma. So abdominal trauma, renal trauma, if they say investigation of choice for renal trauma, that means patient has abdominal trauma with hematuria. What will you do? Investigation of choice for renal trauma, CCT. Investigation of choice for renal trauma, CCT. However, if they say investigation of choice for renal trauma, but the patient is hemodynamically unstable, then what will you do? Very important question. Now we all know by now, in my different parts of class I have told you, if the patient vital is not stable, you cannot send him to a CT department because he is unstable, he can die anytime. So what will you do? Somebody is saying why not MRI? Pujali Rakesh, बेटा ट्रॉमा के पेशेंट में ना MRI में टाइम लगता है. MRI takes time to do. Usually in trauma you will go for CT, not MRI. You will not see MRI as the answer in any emergency. So renal trauma, CT. But if the patient is hemodynamically unstable, here the answer is different from FAST. In renal trauma, suspected renal trauma, you should do a single shot IVP. I think some bachas got it right. Before laparotomy, you will do a single shot IVP. Single shot IVP means in the operation table, on the operation table itself, you will give intravenous dye and take one X-ray of the abdomen. Why? To know the status of the contralateral kidney or the normal kidney. ट्राई टू अंडरस्टैंड, एक बार समझने की कोशिश करो, नहीं तो गलत कर दोगे. ठीक है, अगर किसी को रीनल ट्रॉमा है और उसका बीपी पल्स स्टेबल नहीं है, आपको उसका सिंगल शॉट आईवीपी करना है बिफोर यू गो फॉर लेप्रोटमी. द रीजन इज, ट्राई टू अंडरस्टैंड, आई विल एक्सप्लेन टू यू. Now suppose somebody has an accident and all these ribs are broken, there is hematuria, you know that this kidney could be injured, his BP is falling, pulse is increasing, you know that he is unstable. Now the problem in these patients is that when you explore as a surgeon, sometimes you might have to decide to do a nephrectomy. आपको decide करना पड़ सकता है इसकी kidney निकालनी. But to do this decision, you need to know the functional status of the opposite kidney. So that is why we document the opposite kidney by doing a single shot IVP. This is not done by radiologists, done by the surgeon themselves, just to document कि दूसरी kidney में function है कि नहीं है, so that they can take the decision of nephrectomy. Ultrasound will only show you hemoperitoneum. It will not show you कि kidney excrete कर रही है कि नहीं कर रही है. नील राठौर, समझ आया? अब वो बोल रहे सीधा एक्सप्लोरेटरी लैब क्यों ना कर ले, पहले लैप्रोटोमी से पहले फंक्शनल स्टेटस डॉक्यूमेंट करना पड़ेगा बेटा. Can you understand now? Can you understand? Everybody follows? Okay. Similarly, as we are looking at renal trauma, I also want to see bladder trauma. In bladder rupture, there are two MCQs that many people are getting wrong. Bladder rupture can be extraperitoneal, intraperitoneal. Any one of you can answer, beta. What will you find in it? Deepti and Basanti and Anmol is again and again asking, sir, why not fast? Beta, fast will show you hemoperitoneum, but it will not tell you the functional status of kidney, which is needed to be known if you have a patient with suspected renal trauma. Okay. Now tell me, bladder rupture, extraperitoneal, intraperitoneal, how to differentiate? We will do a investigation of choice, CT cystogram. Investigation of choice, CT cystogram. You will give the dye through the catheter into the bladder and do a CT scan. If the dye leaks only, if suppose this is your bladder and this is your pubic symphysis, pubis. If the dye leaks anterior to the bladder, if the dye leaks into the pre-vesical space in a shape of a molar tooth, it is extraperitoneal rupture. If it is seen, if the dye leaks around the bowel loops, it is a intraperitoneal rupture. Okay, are you clear? Are you able to understand? So should I repeat? Investigation of choice for bladder rupture, CT cystogram. It can differentiate intraperitoneal and extraperitoneal rupture. If the dye is seen around the bowel loops, that means it is a intraperitoneal rupture. If the dye is only seen anterior to the bladder in the pre-vesical space in a molar tooth-like appearance, think of extraperitoneal rupture. Okay, everybody? Now, so this is some common questions on trauma and stones in the urinary tract. Now let us start to evaluate some images. Look at the CT scan with me. I will label the anatomy. You can tell me the abnormality. This is the liver, spleen, left kidney, Schwann muscle, urinary bladder. Okay. Anybody? Now look at the CT with me. This is a very, very important NEET PG FMG exam question, very often, multiple times repeated. Where is the problem? Where is the problem? Problem is in the right kidney. What has happened to the right kidney? Right kidney in this patient has contracted. That means there is some chronic inflammatory process going on and calcified. This is maybe a chronic process, a dead disease causing calcification of the kidney. Can you name a chronic inflammatory disease of the urinary tract which causes calcification and shrinking of the kidney? Anybody? This is what is called as putty kidney, also called as cement kidney, seen in tuberculosis. TB of the kidney will ultimately lead to calcification of the kidney. It will contract and it will become calcified. So I hope you are able to see this is the kidney which is small and calcified. Think of putty kidney in your MCQ exam. Mark the answer as tuberculosis. Okay, we saw this in a previous NEET PG exam. We saw it in the FMG exam. Very, very important, very often repeated MCQ. Okay, my question to you is this. Let's see if you can answer. Investigation of choice for urinary tract TB. Investigation of choice for urinary tract TB. These vertebrae are normal. This is a CT scan. These are normal vertebrae. Yes. Anybody? Urinary tract TB, investigation of choice is CT urography. CT urography. This condition is also called as autonephrectomy. Okay. ना एक बच्चा कह रहा है प्रिंस कह रहा है एक तरफ ही क्यों है, इन्फेक्शन है ना बेटा, ऐसे थोड़ी होगा इन्फेक्शन दोनों तरफ एक सिमेट्रिकली नहीं होगी ना, मैंने पहले भी बताया था. इट्स अ इन्फेक्टिव प्रोसेस, इट विल बी एसिमेट्रिक. ओके. इन्वेस्टिगेशन ऑफ चॉइस फॉर यूरिनरी ट्रैक्ट टीबी, सीटी यूरोग्राफी. अब हम विल लुक एट सम एमसीक्यूज ऑन यूरिनरी ट्रैक्ट टीबी. Earlier we used to do IVP, now we do a CT scan. So they used to ask a question, earliest IVP finding, moth-eaten calyces. Earliest IVP finding in TB is moth-eaten calyces. I want you to understand, TB is different from other UTI. Baki UTI are ascending from below upwards. tuberculosis of the kidney is hematogenous. It is starting in the kidney. So it is starting in the kidney. Earliest finding, moth-eaten calyces. What will happen to the ureter? What will happen to the ureter? Ureter will lead to, you will see sawtooth or beaded ureter. What will happen to the ureteric opening? So if this is the bladder and these are your ureters, TB will come from kidney into the ureter into the bladder. So it is descending down. So around the ureteric orifice you will have tubercular changes around the ureteric orifice. If you put a camera into the bladder, what is that called as? Cystoscopy. What will you see? If you put a camera into the bladder and do cystoscopy, you will see golf hole ureteric orifice. Golf hole ureteric orifice. And then ultimately, because of TB, the bladder will become thick-walled, small bladder. Anybody wants to tell me? TB में cystitis होगी, bladder fibrose होके छोटा और thick हो जाएगा. TB will lead to a thick-walled, small capacity bladder, which is called as thimble bladder. Thimble bladder is small, low capacity bladder seen in tuberculosis. Are you able to answer all this? So TB में you will earlier see moth-eaten calyces, the ureters will be sawtooth appearance, beaded appearance. Cystoscopy will show golf hole appearance of ureteric orifice. Bladder will be small and fibrosed, called as thimble bladder. Okay. Now एक बच्चा पूछ रहा था कि सर bilateral क्यों नहीं? Let me ask you back. Suppose you have a patient with hyperparathyroidism. Suppose you have a patient with hyperparathyroidism, what will happen to the kidney? In hyperparathyroidism, calcium level will be high. And if you have hypercalcemia, renal medulla on both sides will calcify. You will see medullary nephrocalcinosis. Are you able to understand? अगर hyperparathyroidism होगा तो कैल्शियम ज्यादा होगा तो किडनी में कैल्सिफिकेशन होगी, तो दोनों तरफ होगी. That will be bilateral. Okay. Are you able to understand? The concept is, if you have hyperparathyroidism, you will see bilateral medullary nephrocalcinosis. दोनों तरफ किडनी की मेडुला में calcification. Okay, so Samruddhi is saying, sir, thimble bladder क्या था? Thimble bladder is fibrosed small bladder in tubercular cystitis. Okay, everybody follows? Okay. Now somebody is saying, sir, ये white क्या दिख रहा है? This is dye getting excreted because this is the normally functioning kidney. It is excreting the dye, that is normal. While this is a calcified non-functional kidney, which can also be called as autonephrectomy. Tuberculosis of the kidney leads to a calcified non-functional kidney, which can be called as autonephrectomy. ऊपर वाले IVP में ureter normal है. Yes, ureter normal है. It is peristaltic. It is peristaltic, that is why it is little different, but it is normal. Okay. Everybody understands this? Okay. Now let's, so this is a contrast CT. Investigation of choice for urinary TB is CT urography, which is done with IV contrast. Okay. So we have understood a little bit. So let us look at some miscellaneous questions here about bladder. I am going to give you one question. Let's see if you can answer. Bladder wall calcification is seen in TB. Yes ki no? Bladder wall calcification is seen in TB. True or false? Bolo? The answer is false. In TB, bladder usually does not calcify. In TB, bladder does not calcify. It is the kidney which calcifies. बोलो सर किडनी कर रही है, ब्लैडर क्यों नहीं कर रहा? Because in TB the disease is starting in the kidney, then it is going into the bladder. So by the time we make a diagnosis and the treatment starts, so bladder usually does not calcify. It is the kidney which calcifies. So if you see bladder wall calcification, please mark the answer as schistosomiasis. Are you clear, beta? Many people get it wrong in the exam. Bladder wall calcification, do not mark tuberculosis, mark schistosomiasis as the answer. अच्छा ये बताओ चलो. Name a condition in which the bladder is elongated like a Christmas tree. Now this bladder gets elongated like a Christmas tree if there is a detrusor and sphincter dyssynergy. I will explain. Listen to me. Whenever our detrusor muscle contracts, the sphincter relaxes so that the urination can occur. But suppose you have a spinal cord injury, you have a neurogenic problem. What will happen? The higher control of the bladder is lost. So detrusor is contracting, but the sphincter is not relaxing. So the bladder becomes thickened and elongated. So Christmas tree bladder is seen in neurogenic bladder. It is the appearance of neurogenic bladder. It is because of loss of synergy between the detrusor and the sphincter because the higher control is lost. Okay. And what is this bladder? Confusing statement. उल्टा कर देते हैं उसे. Now if I reverse it, then it is called as the teardrop bladder. It's called as the teardrop bladder or pear-shaped bladder. This is seen if there is something compressing the bladder lower part from the outside. So it is seen in pelvic hematoma or pelvic lipomatosis, pelvic lymph nodes or lymphadenopathy. Okay, should I repeat? Are you clear? Okay, I'm repeating. Now these are like three confusing things. Okay, four actually. I'm repeating, everybody listen to me. Okay, bolna hai answer. Thimble bladder is a chronic inflammatory cystitis of the bladder due to TB. So the bladder is fibrous, thick and small. Thimble bladder. But if they say bladder calcified, schistosomiasis. If they say Christmas tree bladder, neurogenic. If they say teardrop bladder, pelvic hematoma compressing the bladder from outside. Okay, so I'm repeating, teardrop bladder is seen if there is something compressing the bladder from the outside. It could be pelvic hematoma, pelvic lipomatosis, pelvic lymphadenopathy. Okay, clear? Now what happened? Are you clear, beta? So Deblina Chaudhary, I think I have repeated it. So what I'm going to do is I'm going to show you the next image. So I've talked about stone, trauma, TB. Now tell me what condition is this? This is one image which is repeated multiple times in your exam. Anybody of you can tell me what is it? This is your vertebra. These are your psoas muscles, and these are your kidneys. So what has happened to the kidneys? Kidneys are enlarged and have multiple cysts. Multiple large cysts in the kidneys is autosomal dominant polycystic kidney disease. Autosomal dominant polycystic kidney disease. Okay. Schistosomiasis bache is an infection. You can read about it in your microbiology. But ADPCKD, autosomal dominant polycystic kidney disease, the kidneys will be large and will be cystic. There are few questions on autosomal dominant polycystic kidney which are very important. Let me ask you. Investigation of choice, CECT. Screening for polycystic kidney disease should be done with ultrasound. Screening of brain in this condition, in this patient, should be done with. In polycystic kidney disease, why would you do screening of his brain? In polycystic kidney disease, why would you do screening of his brain? To look for associated berry-aneurysm. So what will you do? MR angiogram. MR angiogram. Very good, betas. So are you clear? Investigation of choice for polycystic kidney disease is CCT. Screening should be done with ultrasound, but screening of the brain in this condition should be done with MR angiogram. I will explain. Give me 1 second. The question here is this. Let us try to understand polycystic kidney disease and related questions. Question number 1 is, let's try to understand, there are two types of polycystic kidney disease: autosomal dominant, autosomal recessive PCKD. What is the radiological difference between them? Autosomal dominant polycystic kidney disease will have large cyst scattered in the renal parenchyma. Large cyst scattered in the renal parenchyma. Autosomal recessive or the infantile variety will have small cyst radiating from the hilum. Small microscopic cyst radiating from the hilum. Okay? Everybody understands? Now, how will that reflect in the appearance? First of all, I want you to understand, if a disease is autosomal dominant recessive, it will be bilateral. So both the kidneys will be involved. If you do an IVP or you do a contrast CT, whenever I give IV contrast, renal parenchyma will take up the dye. So renal parenchyma will take up the dye, but the cyst will not take up the dye. Renal parenchyma will take up the dye, cyst will not take up the dye. Here also renal parenchyma will take up the dye, cyst will not take up the dye. So because the cyst will not take up the dye, they will give rise to an appearance which is Swiss cheese appearance in ADPCKD and a striated or sunray appearance in ARPCKD. ADPCKD Swiss cheese appearance, ARPCKD sunray or striated appearance. Because the morphology is different, the pathology is different. That is why radiology is different. In ADPCKD, if these are your pelvic calyceal system, the large cyst will compress the pelvic calyceal system. Large cyst will cause pressure on the pelvic calyceal system. As a result, your calyces will all be stretched. These are called as spider leg calyces on IVP. So there are 3 MCQs here. I am repeating the MCQs, don't worry. First is, in which type of polycystic kidney disease do you have sunray appearance? The answer is ARPCKD. In which type of polycystic kidney disease you have Swiss cheese appearance, spider leg appearance? ADPCKD, autosomal dominant polycystic kidney disease. Okay? Now, my question is this. Let's see if you can answer better. Okay? Very important questions. And they have to be done together. I want you to have patience and I want you to stretch out of your comfort zone. Okay? Because I want to make sure that every question is covered in the class. I don't want you to go here and there and find out anything else. You will find everything in the class itself. Okay? Just some patience and we will be able to do it. Patience. Now tell me. The question that I want you to answer is, okay, let's see if you can answer. How will you do screening of a family member of a patient with ADPCKD? Okay. How will you do screening of a family member of a patient with autosomal dominant polycystic kidney disease? It will be done with ultrasound. Okay. So Swiss cheese appearance is seen in C, CT, IVP. Both of them will show you Swiss cheese. That is correct. Spider leg on IVP. है ना? अब बताओ बेटा. All family members of a patient with polycystic kidney disease, because it's a genetic disease, should undergo ultrasound. Okay. Now see. On ultrasound, the criteria is divided into two types. Family member with classic polycystic kidney disease gene positive. Genetic analysis not available. Okay. There are two things. Either the relatives have already done their genetic analysis or they have not done. If they have done and the PKD gene is positive, the criteria is different. If the genetic analysis is not available, criteria is different. Please see. If the family member is between 15 to 29 years of age and the classic gene is positive, if you have more than equal to 2 cysts in both kidneys, that means total of 2, you will call it polycystic kidney disease. If the family member is between 30 to 59, then you need more than 2 cysts per kidney to call it polycystic kidney disease. Okay. If you have a family member more than 60 years of age, more than equal to 4 cysts per kidney. Okay. Everybody, should I repeat? For the family members, if the genetic analysis is done and PKD gene is positive, then depending on the age, if he is a young person 15 to 29, total 2 cysts are seen on ultrasound, you will call it polycystic kidney disease. 30 to 59, more than 2 cysts, more than equal to 2 cysts per kidney. More than 60 years, you need 4 cysts in each kidney to call it polycystic kidney disease. Okay. Now, if the genetic analysis is not done, then the criteria is 15 to 39 years of age, more than equal to 3 cysts in both kidney put together, 40 to 59 years of age, more than equal to 2 cysts per kidney, more than 60 years of age, you need more than equal to 4 cysts per kidney. Okay. So the difference is in the first criteria, which is this. If the gene is positive, even if we see 2 cysts, we will call it polycystic kidney disease. If the genetic analysis is not available, then we need 3 cysts to call it polycystic kidney disease. Okay. Everybody understands? So you will see it is a very complicated concept. And you might think that sir has taken long time for me. But what is happening is, what you're not realizing is that I have actually saved your time. If you read it from Harrison and all, you will get confused. I have made the table in your notes itself. This is the screening of ADPCKD. Okay. Screening for ADPCKD in family members should be done with ultrasound. Criteria depends on whether the genetic analysis is available or not and what is the age of the family member. Okay. Now let me confuse you. Let me further confuse you. Multicystic dysplastic kidney. What is multicystic dysplastic kidney? Is it same as polycystic kidney disease? So one bacha is saying how to remember the age. Just like I am remembering by doing it again and again. Revise your notes again and again. Okay, beta? Tell me now. What is multicystic dysplastic kidney? Multicystic dysplastic kidney is a different disease. What is it? It is a developmental mistake. It is a developmental disorder. If the mesonephros and metanephros fusion abnormality are not fusing properly, if the metanephros and mesonephros are not fusing properly, it is a developmental error. Unilaterally, you will see cysts, but no renal parenchyma. Okay, I am repeating beta. I am repeating again beta. Okay, I am repeating. मल्टीसिस्टिक डिस्प्लास्टिक किडनी एग्जाम में आता है, बच्चे गलत कर देते हैं. वाई? बिकॉज वो सोचते हैं कि सर थक गए थे तो हमने क्लास उस समय छोड़ दी थी, पेपर में वही आ गया. सो इंपॉर्टेंट थिंग इज पॉलीसिस्टिक किडनी डिजीज इज अ जेनेटिक प्रॉब्लम. मल्टीसिस्टिक डिस्प्लास्टिक किडनी इज अ डेवलपमेंटल प्रॉब्लम. यूनिलेटरल, मल्टीपल सिस्ट्स, but no renal parenchyma. So what will you see on IVP? What will you see on IVP? It will not be visualized on IVP because it is not functional. What will you see on ultrasound? Cyst looking like a soap bubble appearance. Okay? Everybody understands? क्लियर. एक बच्चा कह रहा है सर अल्ट्रासाउंड फैमिली मेंबर का. बेटा आप सोच नहीं, ARPCKD तो इन्फेंट में आ जाएगा ना, ADPCKD होता है अडल्ट में, तो उसके परिवार को हमें देखना पड़ेगा. क्लियर. नाउ मल्टीसिस्टिक डिस्प्लास्टिक किडनी इज डेवलपमेंटल, यूनिलैटरल, नॉट सीन ऑन IVP बिकॉज देयर इज नो फंक्शन, नो रीनल पैरेंकाइमा. ऑन अल्ट्रासाउंड देयर इज सोप बबल अपीयरेंस. एवरीबडी अंडरस्टैंड्स? ओके. नाउ suppose you see a renal cyst. How will you describe it on a contrast CT? Anybody? Suppose you have a kidney cyst. How will I write the report? To see, Abhishek, let me answer your question. To see anything on IVP, we need that tissue to take up the dye and excrete. If the kidney is not there, then the dye will not be taken up. Okay, now tell me, renal cyst. Any one of you can answer. Renal cyst on CT scan should be reported as, with a nomenclature called as Bosnack classification. Okay, so renal cysts on Bosnack categories are written as 1, 2, 3, 4. If it is a simple cyst, Bosnack type 1. If it is minimally complicated, Bosnack type 2. Okay, so I am repeating beta. Please एक बार ध्यान से कर लो, घबराओ नहीं, इसको करना है हमें, है ना? Okay, so one बच्चा saying sir workbook मिले. So there is some yellow stickies available in the stationery shop. Stick it there if you want to add more. Okay, so renal cysts are described with Bosnack classification. Type 1, simple cyst. Type 2, minimally complicated. Now tell me anybody, if you find Bosnack type 1, type 2 cyst, ignore them. They are benign. Nothing is to be done. Type 3 is indeterminate cyst. Type 4 is a clearly malignant appearance. Bosnack type 3 and 4 need surgical evaluation. Okay, so I'm again repeating. If you find cyst in a kidney incidentally, either we are dealing with a benign simple cyst or you're dealing with a RCC which is appearing cystic. That is why Dr. Bosnack described a special classification that renal cyst should be described as type 1, type 2, type 3, type 4. Type 1 and 2 ignore, 3 and 4 surgical evaluation. Okay, and you will do them on a CECT. So usually if you discover a renal cyst on CECT, the problem is suppose you get a CT done and on a CT you discover renal cyst. Now the question is it benign? Is it malignant? So the radiologist has to use a nomenclature called as Bosnack classification. Okay, so Gitanshu, multicystic renal dysplasia and multicystic dysplastic kidney are same, means the same thing. Okay, renal cyst we will never suspect, they are incidentally picked up on CECT beta. Okay, now with this background let's look at now some quick images only some named signs are left. Only some named signs. I will take 10 more minutes and we will finish the class. Okay. This is the ureter of the patient. These are your calyces. In this patient, the collecting ducts are dilated. Collecting ducts are dilated. Collecting ducts are dilated. Can you name a condition in which the collecting ducts are dilated? Anybody? Are dilated in a paintbrush-like appearance or bouquet of flower appearance. Name a condition in which the collecting ducts are dilated with a paintbrush appearance or bouquet of flower appearance. Now, what is bouquet of flower appearance? Everybody listen to me. Everybody wake up. It's early morning. It's early morning and you have got a good rank in the exam. And after you get a good rank in the exam, this is me presenting to you. What am I presenting to you? Tell me. I am presenting to you a bouquet of flowers. This is what is called as bouquet of flower appearance. So bouquet of flower appearance is seen in a condition where you have dilatation of the collecting ducts. What is the condition called as? Medullary sponge kidney. So sometimes they confuse you in the exam by saying, in which condition do we have bouquet of flower appearance? Medullary sponge kidney. It is dilatation of the collecting ducts which is causing this appearance to be formed. Okay, beta? Now, but do not get confused between bouquet of flowers and flower vase appearance. Can you name in which condition do we see flower vase appearance on IVP? In which condition? And I am sure that you are waiting for the bouquet, and I am telling you, you will come to this studio and give an interview here. Okay, make that as your target. And I am telling you today, I have interviewed so many students in the last 22 years that many of them, when they come on this table side here, they say, sir, I don't know what to speak, sir, I am feeling so nervous. So don't feel nervous on that day. Start writing today only. Okay, this is, sir, मैंने सोचा नहीं था कि मेरे को इंटरव्यू देना होगा. अभी सोचते हैं, लिखना शुरू कर दो. Okay, so flower vase appearance on IVP is seen in horseshoe kidney. What is horseshoe kidney? Horseshoe kidney is, listen to me, everybody, listen to me. Horseshoe kidney means that suppose these are my kidneys. Look at me, everybody, look at me. These are my kidneys. Suppose my kidneys are rotated and the lower pole are fused. This is called as horseshoe kidney. So horseshoe kidney would have, I will show it to you. This is an IVP image. Okay. And I want you to see with me. These are your ureters. Ureters are appearing close to each other because the kidney is fused. These are your calyces. Lower pole, middle pole, upper pole. And you can see your calyces are also mal-rotated. So this is what looks like a flower vase. Flower vase appearance on IVP is seen in horseshoe kidney because the calyces are mal-rotated and the ureters are close to each other. Okay, now tell me, anybody, what happens to the lower pole calyces? Lower pole calyces in horseshoe kidney are facing each other. Normally the calyces should be outward. In horseshoe kidney, the lower pole calyces are facing each other because the lower pole is fused. It looks as if they are shaking hands with each other. This is called as handshake sign. This is called as handshake sign. Okay. Now tell me two signs of horseshoe kidney. Flower vase appearance, handshake sign. Flower vase appearance, handshake sign. Okay. My question to you is this. Is it easy to diagnose? No. That means the investigation of choice is something else. Investigation of choice for horseshoe kidney is a CCT. Investigation of choice for horseshoe kidney is CCT. Okay, now tell me, are you able to identify the problem here? This is your kidney, right side. This is your left kidney. What is this? Isthmus. So can you see this structure here? This is your kidney, isthmus, the other kidney. This is the horseshoe kidney on CT scan. Investigation of choice, CCT. CCT. My question is this. When the horseshoe kidney ascends from pelvis upwards, at the level of inferior mesenteric artery, the isthmus gets stuck. It cannot go above that. So always remember, horseshoe kidney is at the level of inferior mesenteric artery. It cannot go above it because of the isthmus in the center. This is the isthmus that I am talking about. Okay. Now, only one, you can see only one or two miscellaneous images are left. Which side is the problem? Right side, right side. If your right mid-ureter has fish hook appearance, can you see it here? What will you think? Anybody? If your right mid-ureter, you can see here the ureter on the right side appears to hook around something, what will you think? If your right mid-ureter has a fish hook appearance, you will think of, anybody? Retrocaval ureter. What is retrocaval ureter? An IVC development error. During inferior vena cava development, if there is an error, then the ureter hooks around it. So you see the right-sided ureter will become like a fish hook. Fish hook appearance of right ureter is retrocaval ureter. Okay, miscellaneous, just 2-3 miscellaneous things. Now I want all of you to look at this image and tell me, ureters are close to each other. Ureters in this condition are medially deviated. My question to you is, if the ureters are close to each other, is this horseshoe kidney? Is this horseshoe kidney? Yes or no? No. Why not? Because the calyces are not rotated. The calyces are not malrotated. So medial deviation of ureters is seen in a IgG4 related disease. Can you name the IgG4 related disease which is causing this? Retroperitoneal fibrosis. So if there is retroperitoneal fibrosis, that fibrosis will bring the ureters close to each other. It is a IgG4 related disease, retroperitoneal fibrosis. This appearance is called as maiden waist appearance. This appearance is called as maiden waist appearance. Now what is maiden waist appearance? I want you all to understand the beauty of radiology. Please see, these are your kidneys. As compared to kidneys, the ureters are close together like the shapely waist of a maiden, almost poetry. In medicine, if you look at radiology, you'll find it poetic. She walks in beauty, you can see, and you can see the maiden waist appearance in retroperitoneal fibrosis. Okay, and you thought radiology was only black and white, boring, but it is poetic. Quick, previous NEET PG question. Congenital dilatation of the distal ureter. Congenital dilatation of the distal ureter is uretrocele, uretrocele, and the appearance is called as adder head appearance, or we can use the word cobra head appearance. Adder head appearance, cobra head appearance seen in uretrocele. And this is the same direct image from my book that has been asked in a previous NEET PG exam. So keep it in mind. This is what is the cobra head. Congenital dilatation of the distal ureter. Okay. Final two images and we are closing the show. Identify the investigation. MCU. What is MCU? For the chota bachas and bada bachas, because radiology is difficult for everybody, micturating cystourethropy. What is MCU? Micturating cystourethropy. अब भाई हमें तो ठंडी रोटी ही अच्छी लगती है. कई बच्चे बोल रहे हैं सर रोटी ठंडी हो जाए. हमें तो ठंडी अच्छी लगती है क्योंकि समय मिला ही नहीं जिंदगी में कभी, हमेशा भागते ही रह गए, है ना. हमें तो मजा ही आता है यार, काम में मजा आता है. हम तो घर पहुंचते रोटी बनी नहीं रहती. कई बार ऐसा हो जाता है. कई बार हम सड़क पे खा रहे, रास्ते में खा रहे, हम तो भागते ही रहे हैं जिंदगी भर, है ना. बिकॉज वेन यू कम आउट ऑफ अ background where there was nobody to, we never had a big background. I built everything myself. So time तो पता ही नहीं चलता कभी भी. That is okay. And what is MCU? Micturating cystourethropy. You catheterize the patient, fill up the bladder, ask the patient to micturate with the dye. So now you can see the urethra. Where will you do MCU? Investigation of choice for VUR. Investigation of choice for posterior urethral valve. Two questions, always remember, MCU. Investigation of choice for vesico-ureteric reflux, MCU. Investigation of choice for posterior urethral valve is MCU. Now understand now, why is this reflux important? Because if you have reflux, it can go into the kidney. And when the infection goes into the kidney, it will cause acute pyelonephritis and then it will become chronic. Okay, so it will, if the urine is refluxing from bladder into the kidney, it can also take the infection into the kidney. It can cause pyelonephritis. So that is the importance. I will talk about it further in the subsequent class. And look at this investigation now. Look at this investigation. What is VUR? VUR is vesico-ureteric reflux. Ajender, bladder से ureter में reflux हो रहा है बेटा. So I am repeating the procedure. You catheterize the patient, put the urinary catheter, fill up the dye into the bladder, remove the catheter, ask the patient to micturate. You will see bladder and the urethra. Okay. Now anybody tell me. Suppose I keep the catheter only at the tip of the urethra, inject the dye. This is retrograde urethrogram. Retrograde urethrogram. Where do we use it? Investigation of choice for urethral trauma. Retrograde urethrogram. Okay, I will show it to you, beta. Sometimes they ask you which part of urethra. So remember now, please see. Everybody, part of urethra below the bladder is prostatic urethra. Part at the level of pubic symphysis is membranous. Then you will see a hanging part like this, a comma-shaped hanging part like this. That is the bulbar urethra. Then the straight part, which is the penile urethra. Sometimes they ask you to identify, beta. Sometimes they ask you to identify. Don't get confused. I am again repeating. Part below the bladder, prostatic urethra. Small part at the level of pubic symphysis, membranous urethra. Then you have the bulbar urethra, penile urethra. Okay. This year in NEET PG they had a picture where they had a bladder injury. They said urethral injury. They said where is the injury? So if you know the anatomy, you will be able to pick it up. If the dye is leaking from here, then means it is bulbar urethral rupture. Okay. So but if you have never seen it, you will be confused. So that is why I said let us see the normal images of MCU, RGU. MCU, the bladder is full and the patient is micturating. RGU, you are injecting dye only into the urethra. Why retrograde? Why retrograde? Because retrograde का मतलब यूरिन की फ्लो की डायरेक्शन से opposite डायरेक्शन में डाई डाल रहे हैं. Micturating में antigrade है. The dye is coming from bladder into the urethra. Here we are injecting the dye in this direction. Okay, that is why it is called as retrograde urethrogram. Everybody understands? Okay. And somebody saying renal cyst, CECT, kidney के tumors में, kidney में अगर नहीं समझ आएगा, we'll go for CT बेटा. Ramya Krish, we'll go for CT. Okay. Now is the time to go for the customary quiz that we need to do before we go. We have to do the rapid fire quiz before you go. Okay. Are you ready now to feel the enthusiasm, to feel the power in the night? Let's see now. Look at the first question. Subperiosteal erosion is a feature of subperiosteal erosion. In which condition do we see subperiosteal? कहां पे बताया था मैंने? जल्दी जल्दी बताओ. Anybody? Subperiosteal resorption कहां बताया था मैंने? Always remember hyperparathyroidism. Hyperparathyroidism is the answer. Everybody gets it? Yes? Great. Second question now. Onion peel appearance is seen in which condition do we see onion peel appearance? Oh my God, I've forgotten. Remember. Ewing sarcoma. Onion peel appearance, Ewing sarcoma. Fraying at the ends of the long bones. कहां पे बताया था मैंने? Cupping, splaying, fraying. Fraying at the end of the long bones is seen in. Fraying कहां पे था? Anybody? Fraying at the end of the long bones is seen in rickets. Clear? Cupping, splaying, fraying, rickets. Calcification of meniscal cartilage is a feature of. Anybody wants to tell me? Calcification of meniscal cartilage. सोच के बताना. Cartilage कहां पे calcify होता है ना? And if you remember, I told you, calcification of cartilage is chondrocalcinosis. Chondrocalcinosis is seen in if you have pseudogout, if you have calcium pyrophosphate deposit. Calcification of meniscal cartilage is pseudogout. All the following are radiological features of TB of the spine. TB में क्या होगा? Paravertebral abscess, correct? In TB you develop large paravertebral psoas abscess, cold abscess. So TB is known for cold abscess. So the pus from the TB of the spine goes into the nerves, into the muscles, causes psoas abscess. And psoas abscess will lead to flexion deformity of the hip. So that is correct. Vertebra can be collapsed, joint space can be reduced. Osteoblastic response does not go with TB. TB will always lead to osteoporosis. Okay. So B is not the correct answer. Clear? So which except was the question. Epiphyseal enlargement is seen in. Remember I told you, if you have an inflammatory condition around the knee in the child, seronegative, what is the answer? Juvenile rheumatoid arthritis. Some children at that time were saying GRA क्या होता है? Juvenile rheumatoid arthritis. It leads to enlargement of epiphysis. Everybody clear? Okay beta. Let's see if you can answer. Geographic lytic lesion in the vault of the skull with beveled edges. बेवल्ड एजेस कहां पे बताए थे मैंने? मल्टीपल माइलोमा में तो पंच्ड आउट थे. बेवल्ड एजेस किसमें थे? लैंगर हैंड सेल हिस्टोसाइटोसिस. लेकिन वो तो चॉइस में ही नहीं है. इफ हिस्टोसाइटोसिस इज नॉट गिवन इन द चॉइस, लुक फॉर सिनोनिम्स. इट इज ऑल्सो कॉल्ड एज eosinophilic granuloma. Everybody gets it? Clear? Supercharged? Okay. About osteogenesis imperfecta.